Hi everyone. So first of all, I'd like to welcome you to this mega recall session by the DAMS faculty members. Today we will be recalling the questions that have been asked in this year's INICET paper. Just give us a thumbs up and let us know if you are able to see us and hear me. Just give me a thumbs up in the chat box जो लोग मुझे देख पा रहे हैं सुन पा रहे हैं. So before I answer the questions, I'll just quickly give you a quick overview of this year's paper. मॉडरेट डिफिकल्टी लेवल पेपर. ऐसा लग रहा था कि आसान है, आसान नहीं है. मॉडरेट डिफिकल्टी लेवल का पेपर है, लेकिन इट इज़ नॉट एज डिफिकल्ट एज व्हाट वी गॉट इन द नीट पीजी इवनिंग पेपर. तो नीट पीजी जितना मुश्किल नहीं है, बट इट्स अ मॉडरेट डिफिकल्टी पेपर. सेकेंड ऑब्जर्वेशन, शॉर्ट सब्जेक्ट्स कम आए. Okay, short subjects were less there, and there was a lot of second year in the paper, a lot of microbiology, a lot of pharmacology, a lot of first year physiology in the paper, and a lot of conceptual questions with factual questions. PYQ कम थे, image based question थे, लेकिन कम थे, और साथ में there were a lot of questions on multiple completion. Match the following बहुत ज़्यादा थे, आसान थे. Psychiatry में एक match the following था, direct था, एकदम आसान था. So this was the entire model of the paper. It was doable, moderate difficulty level, less short subjects, more focus on first second year. In the first second year, more focus on the second year subjects, and also a different style of question paper. Usually time management was not a issue in this paper. Most of the students were able to finish the paper on time. बस एक block थोड़ा लंबा था, third block was slightly longer. Okay, so this is the moral so far. So let's look at the radiology questions very fast. Identify the structure marked by the arrow. These were the four choices: posterior auricular artery, middle meningeal artery, superficial temporal artery, ophthalmic artery. Now, the only thing that I thought was that many students were thinking that in the paper, the arrow was either at this or arrow was at this. So when I asked most students, most of them were of the opinion that there was an arrow marked at the outermost blood vessel on the MR angiogram, and it was not arising from the internal carotid, it was arising from the external carotid. So if you agree, give me, let me know in the chat if you agree that this was the question. If you agree, this was the image. Okay. So most of the students were of the opinion that the arrow was at the outermost part of the MR angiogram. It was not arising from the internal carotid artery. It was arising from the external carotid artery. Do you agree or not? Do you agree or not? So if you think this was the image, just let me know. If you think this was the image, then the answer will be superficial temporal artery. Then the answer will be superficial temporal artery, because the arrow was at the most outer blood vessel that is marked here. That was superficial temporal artery. If this vessel was marked, if the blood vessel marked was this one, then we would have thought of middle meningeal artery. So ब्रांच एक्सटर्नल कैरोटिड की है, पक्की बात है, लेकिन सबसे बाहर वाली थी. दैट इज व्हाई वी आर कीपिंग सुपरफिशियल टेम्पोरल आर्टरी एज द आंसर. ओके. ओके बेटा, सेकंड क्वेश्चन. If you remember in my class, I told you examiners love stone. Urinary tract stone, NCCT gallstone, ultrasound. ये मैंने बताया था क्लास में, याद आ गया? यही क्वेश्चन था. What is the IOC for ureteric stone or ureteric colic? The answer remains NCCT. Answer remains NCCT. Direct repeat from your class notes in the INICET paper. Third question thoda tricky hai. So if you remember in my class, I told you infections which spread via endobronchial route will lead to tree in bud appearance. And we talked about tuberculosis is being a classic example of tree in bud appearance. Okay, beta? So this year in the exam, they had a question like this. Okay, everyone see. Diabetic patient, pleural effusion, tree in bud appearance, lymphocyte in the pleural fluid, low ADA level. अभी यहां तक जब हम देख रहे थे, when we saw the first four lines of the question, according to radiology, it is tuberculosis. But देखो, मैंने बताया था कि नहीं, INICET में they will have a twist. They have added low ADA. Now this low ADA does not go with TB. Are you able to understand this or not? Low ADA does not go with TB. So can you see now? Classic radiology picture. Every year I teach this is tuberculosis. They add a twist. Low ADA. Now I'll leave it to the respiratory doctors also. Dr. Bharat, the best teacher ever for respiratory medicine, will be coming, and all your DAMS teacher will be coming and telling you the answers. But I feel because ADA is low, this is the twist of the question. This is the twist of the question. Twist. देखो, लग रहा है TB, लेकिन twist है, ADA नहीं है, ADA कम है. So we'll probably it will be a fungal thing. But let us see what Dr. Bharat says, and we will discuss it again later. Immunocompromised है, diabetic है, Fungal hyphae could be the answer. Okay. Okay. Clear? Okay. Next is a question that I'm sure we've always discussed. You've discussed in surgery also. JIT में भी Dr. Rajiv Tiwari ने भी दिखाया आपको, Dr. Gaurav ने भी दिखाया. All the faculty members have shown you this image. Old patient, long-standing dysphagia, halitosis, bad breath. You could see an outpouching in the upper esophagus. This was definitely Zanker's diverticulum. Slight change every time in INICET they show achalasia. इस बार वो Zankers दिखाया उन्होंने. इस बार उन्होंने Zankers दिखाया, but this was definitely Zanker. Okay. So question number 3 that some of you are asking, probably, I feel that they have on purpose played this game. सब कुछ TB का लिख दिया. Everything is about tuberculosis, but they put low ADA in the question. That is a twist. That is a twist. Let's see what Dr. Bharat answers, and we'll discuss it again with him. Now we're coming to the most controversial question in the paper. This is a patient where the question seems incomplete. A patient has trivial trauma, 68-year-old, some hip pathology is there, some leg fracture probably is there, and they are saying, is it TB, brown tumor, metastasis, eosinophilic granuloma? Ab dekho beta. Eosinophilic granulomas are seen in children. So the question should have been a child. At this age, I am not thinking of eosinophilic granuloma. This is ruled out. Now I want you to look at the image. I don't have the image because everybody is answering a different image. But are you clear with this image? Now see, when I ask most students are saying that the entire of the acetabulum was destroyed. Entire of the acetabulum was destroyed. It was totally gone, and the femur head was seemingly hanging there with all destruction here. Now my question to you is, if it had, okay, now there are two problems here. If the question had fever and loss of joint space, we would go with TB. If there is some evidence or something else in the question suggesting hyperparathyroidism, I will go for brown tumor. But if there is nothing else, just destructive lesion in an old person, I would keep metastasis on the top of the line. I'll keep the metastasis on the top of the line. But the only problem with the question is I don't have the real image, and the history that you're giving is insufficient to differentiate metastasis and brown tumor. So I want to tell you, now people are saying there is no history of fever, so I'm removing fever. Joint space lost, maintained. So we don't know. So all that most people are saying is that acetabulum, when I ask many students, they say acetabulum was destroyed, femoral head was displaced, and the acetabulum destroyed. So the joint is not lost. Any inflammatory arthritis, you will have a loss of joint space, which is not there. Remember the Femistus triad, loss of joint space, erosions, osteoporosis. Here they are saying acetabulum destroyed. Okay, so if this is the question, I might be tempted slightly towards metastasis, but take it as a preliminary answer. I have to keep brown tumor also as a possibility. It is one of these two. I am not really clear with the images that are being shown, and I have asked many students, nobody is able to confirm what is the exact image. If you have the exact image in this question, do share it on the Telegram group, Radiology Unplugged, or the DAMS official group. I will be there and we'll look at the question again. I'll come back to it. Okay. And some students are saying fever was there, somebody is fever or not there, somebody is saying tibial fracture was there, somebody is saying shaft fracture was there. So if it is shaft fracture, maybe one of the possibilities in my mind is, was it a fracture or was it a like a loser zone kind of a thing? So we have to look at this question at more length once we have the exact images. Okay, this is the trickiest question out of the radiology. Rest all were direct. One is Zanker's diverticulum. One looks like TB but low ADA, tilting it towards maybe fungal. Ureteric stone, NCCT direct from your notes. Outermost vessel, probably superficial temporal artery. If this was the artery, then middle meningeal artery, beta. But probably most people are saying this is the artery. Now, I will ask Dr. Deepti to join in with a quick review of the obs and gynae questions. And we have a score of faculty members all excited to share their opinion. Is bar, I am sure, with the paper, which is totally conceptual, you will appreciate that the exam needed detailed study. And I'm very happy DAMS teacher have the highest strike rate in this paper. So let me invite Dr. Deepti.
Hey everyone. So a very good evening to all of you. And sabse pehle, so how was OBG for everyone? I hope you have all done well in Nobs and Gynae, and I hope that you are happy with how you have performed. Yes, everyone, how was it? Okay, great. So I'm so happy that you have good number of questions in Obs and Gynae, and I think almost everything is from notes. But yes, you are the best people here to give us the correct feedbacks. And we are here. So I have already shared all the questions and all the answers in my Telegram group with the images from the notes, right? From your back to basics, from your live classes, right? And right. So people are saying it was easy. I'm happy. I'm just going to pray that all of you do really well. So let's quickly look at the questions. So the first, sorry. So which is not a germ cell tumor of the ovary, right? So the answer is going to be the juvenile granulosa cell tumors, right? Yes, even if they say juvenile granulosa cell tumors are sex cord tumors of the ovary, they are not germ cell tumors, okay? So dysgerminoma, choriocarcinoma, yolk sac, they are all going to be germ cell tumors. And yes, I have just shared a picture from the notes as well, where I've given it to you in a tabulated manner. Okay. Then there was a question on restitution. I don't know the exact language of the question, but I've tried to get the recalls, right? So one of the options, you have to tell me if the correct recall is there or not, because I don't have the fourth option here. So one said torsion of head after shoulder comes out. So that is incorrect. It is not the torsion of head. It is actually the untwisting or reducing the torsion, right? Then there was another question which said head torsion of 1/8 which occurs due to movement of the shoulders. No. So at the time of restitution, there is no movement of the shoulders, right? So here we are going to go with it is a visible passive movement due to untwisting of the neck, right? So it was a visible passive movement due to untwisting of the neck that happens during internal rotation. Again, something that we talk about at length in the classes as well. We talk about the sequence of changes, we talk about restitution, we talk about crowning as well. So I hope you've got it right. I am super happy with this question because this is a typical example that I give in my classes. I even write the word athlete and runners, right? So if you have attended the class, then you know what I'm talking about, right? So we are talking about higher centers not functioning normally. So I have also shared a snapshot where I have written that FSH levels, okay, FSH levels which are less than 4, that is 1 to 3 international units, are considered as suppressed levels, which means the FSH is not coming from the higher centers. The LH is also low, right? So this is definitely hypogonadotropic hypogonadism. Okay, so hypogonadotropic hypogonadism. Okay, and the BMI is less. The also, as I said, I typically give example of 4 types of hypothalamic amenorrhea. Do you remember? Yes, we have talked about stress induced. Then I talk about exercise induced, where I talk about athletes or runners, especially, right? Then it could be chronic malnutrition and anorexia nervosa, right? So these people will have low E2 levels. They will also have low, almost low to borderline normal FSH levels as well. So hypogonadotropic hypogonadism. Okay? Early preeclampsia is before, again, directly from your class notes, especially when I talk about prediction of preeclampsia. So that's where I talk about uterine artery Dopplers and I talk about early Dopplers, which are done to pick up early onset preeclampsia, which is before 34 weeks. So before 34 weeks is early onset, and after 34 weeks is late onset preeclampsia. I hope you've all got these right. Yes. Then again, I don't have the options because probably it was so simple that students don't remember the option, and exactly how we teach in the class that imperforate hymen is going to sometimes have an acute presentation. And if they have acute presentation, it is usually acute urinary retention. Yes, the answer to this question is imperforate hymen. I would request everyone in the chat that if you have options for this question, please let me know the options. The answer, yes, is imperforate hymen. So I'm writing it here. But if you can recall the other options, you can let me know. Okay, till the time you put on the other options, let's look at the next one. Shortest diameter. So again, repeatedly hammered in the classes is obstetric conjugate. It is also used to define what? Contracted pelvic inlet. Yes, where we say obstetric conjugate less than 10 centimeters is a contracted inlet, right? So the shortest one is obstetric conjugate. Okay, thank you. So the other options that the students are saying are a transverse vaginal septum, which will never present with bluish bulging membrane, right? So MRKH, again, MRKH will have an absent vagina, so they don't have a bluish bulging membrane, right? So those are all the options that you are giving me. So this is wrong. Yes, cyclical pain, primary amenorrhea. I always say that these are the key words when we talk about imperforate hymen or transverse septum. I also tell in detail how to differentiate imperforate hymen and transverse septum, right? So here the answer is going to be imperforate hymen. Right. Let's look at the next question. In AMTSL, which is not included. So it looks like a PYQ, but you have to be very careful. They are not, okay. The other option is OHIVIRA. All right. So that is definitely not not the answer here. Okay. Now coming to AMTSL is does not include. So it's not exactly a PYQ. They have changed the options. And again, something that I repeatedly tell you when I show you management of PPH, right? So I even show you this picture because I thought it will come as an IBQ. But anyways, it didn't come as an IBQ. It has come as a separate MCQ. Please remember bimanual compression, where one hand is in the vagina, anterior fornix, the other hand in the suprapubic region. Bimanual compression is never done for prevention or prophylaxis. Massage, you can still do, it won't do any harm, but you can't do a bimanual compression for every delivering or laboring woman, right? So remember, AMTSL is prevention, right? So for prevention, you don't do a bimanual compression. Bimanual compression or bimanual uterine massage is something that you do only when you are treating PPH, and that too once you have ruled out genital tract trauma, right? So please remember. You can give uterotonics after the delivery of anterior shoulder. I think you should read the question very carefully. I have always said that you can ideally give it within 1 minute of delivery of the baby, or I always say, WHO says you can also give it after the delivery of anterior shoulder. So after anterior shoulder is the correct option, beta. It is an alternative way of giving the uterotonic. Again, something that is directly there in your class notes verbatim. Okay. All right. Percentage of unexplained infertility. Again, you can't complain here. They are directly from the class notes. I have given this. I have shared a picture. I tell you that I will tell you very little factual questions, but wherever I tell you factual questions, they are important for your exams, right? So nearly 10 to 15%, right? So here we're going to go with 15% unexplained infertility, where all the tests in the male and all the tests in the female are normal. This is how the question came, that the man has absolutely normal semen analysis. The woman also has normal workup. What percentage of patients have this? So this is what is unexplained infertility, and it is around 15%. Okay. Chalo. Now this again, students did not give me the options. It was too simple for them. So malodorous discharge, and they have given the whiff test positive. Please remember, when we say whiff test positive, I've always said that it is primarily a test done for bacterial vaginosis. I always also say that yes, it can be positive in Trichomonas vaginalis, but that's not the best answer for whiff test. So when we talk about whiff test, then the single best answer should be bacterial vaginosis. Okay. Yes, I just said oxytocin can be given after the delivery of anterior shoulder. It is correct, beta. Ideal is within 1 minute of delivery of the baby, but it can be given even at the delivery of anterior shoulder. It is an alternative thing. But by manual compression, never ever can you do it in AMTSL. Okay. Okay, so people are saying Gardnerella vaginalis. So yes, that's the organism for bacterial vaginosis. So that would be the answer, Gardnerella vaginalis. Okay, right. So they are saying the other options are chlamydia and Trichomonas vaginalis. Okay, thank you so much for those other options. I am grateful to you. Again, I am going to proudly say that I show you these images when I talk about correlation of path and gynecology. I told you always in the endometrial biopsy, I show you images of corkscrew screw glands, right? And we also discuss that this is a finding of late secretory phase, right? Which means it is because of progesterone, which means it is coming from the corpus luteum, right? So corkscrew glands is a finding with late secretory phase, right? So the best answer here is going to be corpus luteum because the reason here is progesterone, okay? All right. Then again, this I don't have all the correct recall because it was a multiple correct type option, right? So now the question says abdominal ectopic pregnancy and multiple correct were there, right? So yes, abdominal pain is the most common presentation. Again, yes, I've been repeatedly talking about other tests that you use apart from transvaginal ultrasound and serial HCG, and that is level of progesterone, yes, is less than what is supposed to be. It is less than expected, but it is not diagnostic because it cannot differentiate between abortion and ectopic. So that is why we don't commonly do serum progesterone levels, but that's correct options. Okay. Then methotrexate is given in place of surgery even if the patient is in shock. No, please. If you had a statement like that, this is a false statement. Okay. We don't give methotrexate if the woman is in shock. Right? So methotrexate, please remember, is only given for unruptured ectopic with stable vitals, absent cardiac activity, HCG value less than 5,000. Yes, and oral methotrexate is anyways not given. So if even if they mentioned oral, it is still an incorrect option. Yes, it has to be intramuscular. Okay, we also talk about doses. Right. PID. What was the statement about PID? Yes, I agree. I don't have the fourth statement. I think it was about risk factors. So I think it said something like PID and previous ectopic are risk factors. Was that a question? Yes. So then that would be a true statement. So PID and previous ectopic are risk factors. That would be a true statement. Okay. Yes, PID, STDs, they are major risk factors, and that's correct. PID is the most common risk factor. Yes, chalo. Now, this question, I'm not sure if the recall is correct. So I'm just going to give a preliminary answer unless you give me the correct things. Okay. So this question is it was a younger girl, 25 years old. She has a history of rheumatic heart disease. She has undergone a valve replacement surgery. Now comes the problem. Some of you are giving me in the recall that there is a 14 week size abdominopelvic mass. Is that correct? Was 14 weeks the size of abdominopelvic mass? But then suddenly you change the mass size to 6 to 8 centimeters, which doesn't go. Okay. So I am not sure which out of the two is correct. So abdominopelvic and 14 weeks is way different from a 6 centimeter mass, which is unilocular. Anyway, what you have to know is, please remember that whenever we use the term reticular, right? When we use the term reticular, it means it is a hemorrhagic cyst. Okay. It is a hemorrhagic cyst, right? And most of the times, hemorrhagic cysts can be managed with simple follow up in case the patient doesn't come with acute pain or with unstable vitals because of rupture, right? So it is a okay. So people are saying yes, both are correct. Yes, on warfarin, probably that's why there has been a hemorrhage inside the cyst. Okay, so please remember, she is pregnant. Oh, you meant to say she is pregnant. I don't know. I didn't have the correct recall. Okay, so this is pregnancy. So, okay, they are saying this is a pregnant woman with, is that what you're trying to tell me? Okay, so probably the wordings in the recall were not correct, right? So this is a pregnant woman who has undergone a valve replacement surgery, right? And she has a mass, then definitely the answer would be follow up. Okay, then we are not operating on her, right? So this is very likely to be hemorrhage in a corpus luteum of ovary, and you're not going to operate, you're just going to follow up. Okay, then there is no problem. Reticular means there is hemorrhage. Okay. Reticular cobweb matlab hemorrhage, right? So now it's no longer a confusion. Okay. So 14 weeks non-pregnant. See, you keep changing. I don't know. Okay. Let's keep it as a preliminary question. See, non-pregnant doesn't make sense. pregnancy, it still makes sense because you're saying one, there is 14 weeks, another you are saying is 6 to 8. It doesn't correlate. It has to be a pregnancy with this mass. Okay. They won't, probably they will not use the term pregnancy, but let's see. Okay. No worries. No, CA 125, I clearly tell in exam has no value. Okay, CA 125 has no value in a young female. That's not the answer, right? Please understand this. Okay. All right. So they are saying P1L1 was given. So not pregnant. Did they mention P1L1? Okay. Some of you are now saying P1L1 was mentioned. Anyways, let's see. So maybe they're saying 14 weeks on per abdomen examination and only 6 centimeters on ultrasound. Still, it doesn't correlate. So we'll see. As of now, we'll keep it as follow-up. But if it is a big mass, then and it's hemorrhagic, we might have to operate as well. Okay. But as of now, we'll keep it as follow-up and then we will see. Okay. Now somebody saying size was more than 8. No, CA 125 has no value here. Okay. It's a unilocular. It's reticular. So this is the hemorrhagic cyst. Chalo, aage karte hain. Okay. A patient has a relative with history of cervical cancer and she is 21 years old. Again, I need correct recall. Low resource setting. Now, I didn't, who is, the patient here is 21 years old or there is a relative, whatever it is. So please remember, I have very clearly said that as per WHO in the resource limited settings, if you are doing a pap smear, right, then we have to do it every 3 yearly. And I have also very clearly mentioned that in resource limited settings or low resource settings, you are going to start screening at 30 years of age and you stop screening at, yes, 50 years. Okay. So anyways, so you have to see which option was correct. Yes, even if it is asymptomatic. Okay. Okay, doctor wants to screen. Now the question is, she wants to screen in this 21-year-old, whatever it is. Please remember, the pap smear has to be done 3 yearly, even in resource limited settings. That is a WHO recommendation. Okay, co-test, no. Low resource countries don't have money to do a co-test, right? Co-test is what they do in US. So we are not doing co-test. Right? So please understand this. Okay, so somebody saying a group of, someone is saying it is a group of asymptomatic women with no risk factors in late 20s. Then it's okay, right? So please remember, although, yes, as per WHO in resource limited, we start at 30 years. But if you want to do in 30 years, then yes, please remember the single best answer is HPV. We can do HPV. The interval can be 5 yearly. But again, HPV is usually not affordable in low resource settings. So which means you have to look for combinations. Okay. Yes, I know it doesn't look like a wrong recall. That's why I'm asking you. You have to tell me what is the right recall. Okay. So दो ही चीजें देखना है. PAPS का interval has to be 3 yearly. And generally we start screening at 30 years. If you are talking about HPV, then the screening for HPV is 5 yearly. Even for co-test, it is 5 yearly. So any combination which says HPV and PAPS at 3 years is incorrect. Okay. Yes, we can do. All right. If we have 30 in the options, then we have to look at 30 wala as a better option in low resource countries. Because as per the WHO guidelines, right, we have to, as I said, start screening at 30. And as per the WHO, the best test, I have also told this, is HPV. So if you have an option which is a combination of 30 years and HPV, which somebody is saying in the chat box, then that is the answer. Okay. So please remember this. If you have a test or an option which said HPV at 30 years, then that is the best answer and 5 yearly. Okay. Because in low resource, The guidelines is to start screening at 30 years and the best test is HPV. So combination of those two would be the best answers. Okay? Yes. All right. Right. Somebody is saying, yes, there was this option like this. So we'll keep it as an option with HPV at 30 years. So I don't have the fourth option. So we will keep it as HPV at 30 years and we will take that as the answer. Okay? Yes, co-test has to be done at a minimum gap of 5 years. You don't do a co-test at 3 years. All right? Okay. So this is again something that we have directly done. When is instrumental delivery not done? What is the answer? The answer is going to be cephalopelvic disproportion. Maternal exhaustion, fetal distress, they are indications of instrumental delivery. If anybody can recall option D, then please let me know what is the fourth option. Okay, somebody is saying question was only with 21 years. See, I've given you both answers. If the question was only with 21 years, then the combo co-test with 3 years is incorrect. Okay, then PAPS with 3 years becomes correct. If there was one option with 30 years in HPV, then that would be the better answer. So let's have the correct recall. Okay, so when is delayed cord clamping done? So again, directly, I've always told you, as long as the baby does not need resuscitation. So a vigorous baby, irrespective of whether the baby is term or preterm. Okay, so please remember this, vigorous baby, irrespective of term ya preterm. So as long as the baby does not need resuscitation, the universal guideline is delayed cord clamping. Okay. All right. Somebody is saying the fourth option was prolonged second stage. Fair enough. That's a okay option. So prolonged second stage is also an indication to do the instrumental delivery. Okay. Now this I think is a problematic question because the options were created wrongly. So question is which is not a component, and if I am correct in the recall, the option said inhibin B also and option said estradiol also. Is it correct? Yes, so inhibin B also and estradiol. So both are incorrect. Okay, we all know it has to be unconjugated E3. Okay, unconjugated E3, estriol, not estradiol. So this is incorrect. So both are incorrect, but a better answer will be inhibin B. Why? Because I would say there is a similar question that they have asked previously in the exams, right? So we would take the better answer to be the one with the inhibin B, considering that it is like a previous question that INICET has asked. Otherwise, yes, even estradiol is wrong. It should be UE3. Okay, the single best will be inhibin B. Alpha fetoprotein and HCG are correct. They are components of quad test. Yes. No, it's not dimorphic, it is dimeric. Yes. So whether it is inhibin A, we use the term dimeric inhibin A. So that inhibin A has to be correct. It cannot be inhibin B. Okay. And the option said inhibin B. Okay. Yes. So estradiol is also incorrect. But what I'm saying is a better answer is inhibin B. Okay. Chalo. This was an easy one, and a lot of questions came from what I said as predictions as well. So physiological changes are all except we know about blood pressure. Both systolic and diastolic blood pressure fall, they don't increase, right? So the answer is going to be increase in SBP because we had to write except, okay? Then this, again, a very basic question, something that you might have done for your NEET UG also. Mitochondria forms what? It forms the middle piece, right? Then there was this question. Now you have to tell me, was dictiotin in the options or not? Can you tell me if dictiotin was in the options? So somebody said dictiotin was not in the options, okay? So please remember, हाइपोग्लाइसीमिया भी करेक्ट है बेटा, मैंने पढ़ाया हुआ है आपको. बिकॉज ऑफ हाइपर इंसुलिनीमिया, pregnant women have fasting hypoglycemia and they have postprandial hyperglycemia. ठीक है. ठीक है. So dictiotin was not in the options. Then yes, the second best answer is diplotine. Okay, it is the specific answer. सबसे ज्यादा specific answer is dictiotin. If that is not in the options, then yes, we are going to go with diplotene. Okay, somebody is saying pachytene was in the options. That's not the answer. I am saying if dictyotene is not in the options, then the answer is diplotene. Okay. Yep. Right. So those are the 19 questions that we have for recall. Right. And as I said, I've already shared all the snapshots from our back to basic videos, right, in the Telegram group. So I'm wishing you all the very best for your results. I just hope each one of you does really, really well and you come out with flying colors and make us all proud. So I'll hand over the mic to the next faculty, whoever is available. So team, can you please let us know which faculty is going to take over the show now? And I hope till then students can reply to me that they are happy. Yes, with the OBGY, I hope you've done well. Right. Yes, I think Dr. Gaurav is here for the surgery recall, but I'm not sure when he will come. We have almost every, faculty member coming up. So don't worry, we will discuss all subjects, right? Okay. So who's sticking?
Hi guys, good evening. And I'm Dr. Sanjeev, and we are having full team of pathology faculties here. I welcome Dr. Shagun and Dr. Gaurav Theri as well. So what we'll be doing is we're going to recall questions from whatever we have got. Just a minute. I'll like to share my, let me see if, is it, okay, I'll just share. Yes, so this should be it. Okay, guys. Yeah, so let's see. This was one question. Please feel free to Shagun and Gaurav Theri, both of you, please feel to add whatever doubts, things that you have recollected.
Yes,
The
sir.
first question which I have got, which of the following isn't inherited, right? Students, this was the question, which is not inherited. Was this the question exactly? Which is not inherited? Right? So in this options were homocystinuria, protein C deficiency, antithrombin 3 deficiency, and PNH, I guess, right? So answer to this question is a PNH. So many times we discussed this in the class. PNH is not inherited, it is acquired, right? Yeah. So this was the question. This was the question. This question, please feel free to, what was TTP not a component or not a part of triad? What was the question asked about TTP? Most common inherited cause of coagulation, that was a different. I am having that question later on. Yes, so that was a different question. Yes, I am having that question. Second question, have we recalled this? Was this the question? TTP not a component of, or what was the question? Please, is it not a triad? What was the question? So I just want to, know this exactly. What was the question about this TTP? Okay, not a component of TTP. So actually, if you look at this, microangiopathic hemolytic anemia was given. That is a part of TTP. So this is not the answer. Renal failure, yes, is a part of TTP. Yes, renal failure is a part of TTP. Organ failure will be there. Thrombocytopenia also, yes. Okay, triad not mentioned, not seen in TTP. So then in this yes, so by ruling out everything, answer will be thrombosis. Although remember in TTP, there will be, we call them platelet microthrombi are there. I hope these were the options. Please tell me now. So if these were the options, then answer will be thrombosis. That is what I would like to go. Or if any other option. See, in this B, C, and D are all present part of TTP. A is plus minus because there will be only platelet thrombi, platelet microthrombi, not the thrombus. Thrombus, when you usually say thrombus, it is a clot, isn't it? Yes. So I hope these were the exact options as well. Options are right. Okay. Then answer will be option A here. Okay. In this, please, Shagun and Dr. Shagun and Dr. Gaurav, please add, and also students, please add blood product not obtained by centrifugation. Was this the question?
Yes. And sir, one of the option that I got was albumin.
Okay. So in this, which one is out then?
I think
Albumin is not.
plasma, B option.
Okay, plasma was not there, and this was albumin.
Albumin.
Please, guys, please tell me, was this the correct recall then? Blood product not obtained by centrifugation, cryoprecipitate, RBC, platelet, and albumin. These were the options. Okay, so serum albumin. Okay, this was serum albumin was given. And in that case, answer will be actually what? Okay, this is very, any blood product, first we have to centrifuge. We call a light spin and a heavy spin. Okay, so light spin is the first one. Whenever blood is collected, 450 ml of blood, we do a light spin. In light spin, RBCs will settle down. There will be plasma on the top. And we take this plasma, we do a heavy spin. And when we do a heavy spin, that is with higher RPM. So when we do a heavy spin, please zoom the slide just a minute. I'll just check. Okay, so just a minute. I'll just ask the technical
Now it
team.
is fine, sir.
Now, is it fine? Is it fine?
Yes, yes. Now it is fine, sir.
Okay, okay. So blood. Okay, so we do a light spin. I was talking about light spin and then a heavy spin. So with light spin, we get RBC. That is also centrifugation. So this is not the answer. Platelets also yes. Cryoprecipitate also yes. In fact, option B, if it was serum albumin, this is not at all a blood product, by the way. Serum albumin is not at all a blood product. In blood products, we are having 4 blood products, which are those packed RBC, FFP, cryoprecipitate, and platelets, right? So this will be the correct answer then. Okay. Yeah. So this was the question. Please, we have to recall the other options or the correct options. Most common cause of inherited coagulopathy. Was this a question? Some people said bleeding was there or coagulopathy. What was the question? Dr. Shagun, do you want to add to this? Answer,
Yes.
if it was coagulopathy or thrombosis, answer will be factor 5, Leiden mutation. Whatever are the other options. Just want to know what was the other options in this?
Sir, I got to know antithrombin 3 deficiency and some said prothrombin also. Prothrombin instead of protein S.
Okay. Antithrombin and this would have been prothrombin. Okay. So answer is yes. Now the fifth one. Yeah, this is one which very difficult. I have not got recalled it fully. Okay, which of the following, please try to recall this correctly, students. Which of the following should be done or should not be done? What was the question? While drawing blood for serum calcium level. Was this a question? So there was a question on while drawing blood for serum calcium levels. Was this the question asked? Yes, which of the following is should be done? Anybody, Dr. Shagun, Dr. Gaurav, any one of you have got this question?
I didn't get this question.
Okay. Okay. Question is which is true, which is false? Nidhi is saying not to be done, which is true has been. Okay. Multiple true false type of question. Okay. So if you remember in test and discussion, I had discussed the blood collection procedure. So let me just tell you what is the blood collection. Citrate in the tube? Never. For calcium, do not take citrate, obviously. Yes. Okay. Please, how to precaution in order to have correct serum calcium level. Okay. That means which of the following has to be done for drawing blood for serum calcium or for having correct calcium levels, right? Correct calcium levels. So few things we were talking about, okay, which will affect, I will tell you now. So few things that we should be doing. First, tourniquet. Most important thing is tourniquet. Tourniquet should be released as quickly as possible. Why? I told you this. Longer you tie the tourniquet, there will be more hemolysis happening. That is one. Second, not only that, longer you tie more hemolysis, that can lead to abnormal electrolyte, including abnormal sodium as well. Okay, one more was prolonged bed rest and immobilization leads to bone resorption. That was the third option. Yes, correct. That is true. Option 4, osteoporosis may rise calcium level, then avoid forearm exercises. Okay, avoid exercises, not an important thing. Okay, so what should be done? One is, this is true. Tourniquet should be removed as quickly as possible within 1 minute. Second thing that you should be taking care is Of course, collect it in the proper tube. Do not collect it in citrate or whatever was given. If needed, tourniquet. Okay, question was not to be done. Do with sodium citrate and oxalate? No. So we will be doing either with heparin or with serum tubes, either of them. Okay. Yes. So it will not be with, okay. One more option was citrate. Definitely not. Citrate, oxalate, no. Even EDTA also no. These will not be. This should not be done. Okay. So this definitely should not, because they are calcium chelators. We cannot be using them. Three options were correct. Citrate was wrong. Okay, citrate definitely is wrong. Citrate, oxalate are wrong. Tourniquet, yes. Do not make fist before phlebotomy. Was this the option? Was this there in the option?
Yes, sir.
Okay, avoid forearm exercises before collection. No, that is false then. Avoid forearm, no need to avoid any exercise before collection. So that is also false. Which should be done? That is also not. Okay, this was not making fist. Avoid forearm. Avoid forearm exercises. This is also false. Chelators were not used in the option. Okay, that is citrate, oxalate should not be used. That is correct. And then one more option was also correct. What was that? You guys said bed rest. Prolonged bed rest can lead to elevated calcium levels. Yes, that is while interpretation, we should be doing that. Okay, that is also true. Okay, not done. Do not make fist and avoid forearm exercise. No, that is false anyway. Do not make fist. No, we have to make fist so that the vein becomes prominent. Not a problem. Making a fist is not a problem. Okay. Remove tourniquet soon. Do not make fist. Bed rest increases calcium. Collect in. Okay. Correct was the question. So in this, remove tourniquet soon. Only 4. If these 4 are there, only best answer will be remove tourniquet. So why should you remove tourniquet? Multiple reasons. Multiple reasons for removing tourniquet already we discussed. One, there can be because tourniquet is tied, increase in hydrostatic pressure will happen, and that is why there will be water will be lost. Water is lost into the tissue, and that is why dissolved substances can go low. Okay, that is why. So that is tourniquet should be removed as quickly as possible. I had told this, expect ideally should be removed once there is blood established or blood flow established into the needle or the syringe, right? Okay. So that is what, or ideally within less than 2 minutes, never more than 2 minutes. And if you are not able to identify the vein, then wait for another 2 minutes and then tie the tourniquet again. Okay, multiple true were correct. So whatever you have given, this is true in this. This is true in this. Bed rest increases free calcium.
Hello.
Multiple choice. Okay, ABC including the first. Okay. Okay, so there were 3. Okay, but then multiple choice, 4 options were there, 5 options were there. That is what we should be knowing then. Okay, so guys, please, you can, I have collected the options as of now. If you still are having any further, then see, but basically permutation combination of this, we know what is, wrong in this, which is not okay. So I think enough with this question, because there will be a lot of, changes in the recall when we are doing this. So please, the concept remains the same. Okay, only 4 options were there. Okay. Anticoagulant used for HbA1c estimation. Was this the question? Anticoagulant used, was this the question, or it was Vacutainer were given in this? Okay. Sodium fluoride, citrate, EDTA, oxalate. Answer to this. So remember, it is not. If you have answered it as sodium fluoride, no. Sodium fluoride is used for blood glucose level. Not for, and also this is not an anticoagulant, by the way, it is a glycolysis inhibitor. Why do we use this for blood glucose level? Because we are measuring one shot blood. As of now, how much is the blood glucose, right? Okay, that is not the answer. Answer is EDTA. We use EDTA. For HbA1c, we use EDTA. Do not confuse this with blood glucose. If they ask blood glucose, answer will be sodium fluoride with oxalate. Okay, which anticoagulant? Yes, correct. So anyway, in that case, sodium fluoride is not an anticoagulant at all. Sodium fluoride is glycolysis inhibitor. So I think citrate was, okay, one more option was also there. 5 options were there, heparin. Okay, answer is EDTA. EDTA. Remember, for blood glucose, we will use sodium fluoride with oxalate, gray tube. Warfarin, I don't think warfarin will be in the option because we don't use warfarin as a vacuum for any anticoagulant in blood. Okay, samples. Okay, oxalate was not there, so this heparin was there. Answer is EDTA. Anyway, answer is EDTA. We had discussed this in the DVT, etc. Okay. Was this an image-based? Next one, please tell me now, was this an image-based question? Dr. Gaurav, Dr. Shagun, have you recalled such a question? In stored blood, oxygen dissociation curve is left, right was given in the option or there was an image? Okay, anyway, the concept, was this a question?
Yes, sir.
Okay, there was a question like this, right? The concept, okay, the concept, we discussed this already in blood banking. Whenever you store the blood, there will be a decrease in 2,3 DPG levels, isn't it? Because DPG levels, this will lead to shift to left. Oxygen curve will shift towards left. In this case, if it was an image-based question, okay. Yes. So, yeah. So, answer will be, in this case, option A is the correct answer because shift to left is there, right? Yes. So there was a curve and there was one more D curve wherever they would have given. I do not know now. So let us make one more D curve like this, right? Then, okay. Yeah. So anyway, so answer is option A, shifted to left happens. Straight line plotted was there. Okay. Anyway, whatever is shifted to left, that will be the correct answer. Shifted to left, that will be the correct answer. How do you avoid this? This we had discussed in the class. To avoid this is, of course, there should be whatever is towards the left. Straight line at 0 going along the left of A. No, it won't be a straight line for sure. Yes, there has to be shifted to left. DPG levels will be low. Okay. Yes, after blood transfusion, hypoxia doesn't get corrected, anemia gets corrected. To avoid this, we use phosphate in the preservative. If you use phosphate, DPG levels will normalize, right? So this is also another potential question. Okay, next question. Okay, this I think ma'am also discussed this. Which of the following is not a germ cell tumor of ovary? Anyway, so yeah, it is after blood transfusion only. In stored blood, after blood transfusion, the curve will be towards the left. Okay, this madam has already discussed. Answer, which of the following is not a germ cell tumor? Anyway, answer is granulosa cell tumor. We discussed this also in class. Yes, please tell me. This was also another question. So there were 3 questions on blood sample collection in this paper, if this was correct. Which value is used for serum electrolyte? Was this the question asked?
Yes, sir.
Okay, so there were 3 questions on blood sample collecting. So in this, best answer will be, if there were these options, best will be option B, green. That is your heparin. That will be the best answer if this is the options. If not, then we will be using a, yes, oxygen saturation on transfusion of packed RBC, they will be shifted to left because there is low 2,3 DPG levels. If green was there in the option, yeah, yellow is also there. Yes, yellow is also there, but that is not the best, will be green. So in this B more than D, best will be green. Yeah. Yes. So best will be green, B more than D. That will be the correct answer here. Okay. Next, question number 11. हाँ, येलो भी था, करेक्ट है, येलो भी है, तब भी येलो से ग्रीन इज बेटर. Okay, was this question, please try to recall options here. I do not know, but anyway, diagnosis of the question. Word, a newborn presents with umbilical cord bleeding. All tests were normal. Was this the question? All tests were normal. Newborn presents with umbilical cord bleeding. All tests were normal.
Yes, sir.
Okay. So all tests were normal. Answer, factor 13 deficiency. Was this in the option?
There was factor 9, sir, and
Okay.
von Willebrand factor as well.
Okay. So 9, then vitamin K would not be there. VWD. Factor 10 was there in the option?
According to the recall, I have got factor 9, 13, 8, and von Willebrand factor.
Okay. 9, 13, 8, and 1 will be. Okay. Yes. So.
And it was mentioned all tests PT, APTT, TT all are normal.
Okay, that's good then. So all tests are normal, right? Okay. Instead of this, they have mentioned PT, APTT, and TT. This is again so many times discussed in the class, right? Factor 13, factor 13. Okay, they had given urea solubility test. Yes, so it will be more soluble to urea. Was that given? Was that given?
Yes, sir.
Urea lysis test positive?
Yes.
Okay.
So the screen is again.
Okay, just a minute. Sorry.
Perfect. No,
Yeah.
sir.
So urea lysis test. Urea lysis test is we use a 5 molar urea and an unstable clot will end up getting lysed quickly. That is what it is. Try to now, this is what I've got the part of recall here. Child presents with fever. Bone marrow aspirate was given and positive for 19, 22 and CD10. Markers. Please tell me. Markers. Were these markers? 19, 22 and CD10. And any history was given. Anyway, diagnosis, if markers, we just have to first recollect the proper markers. Yes, markers. I just want to know what were the markers in this. Okay, image was given. Okay. So image of blast was given. Okay. Image was given and markers. Okay, TDT was also given. Oh, then this would have been very, very easy for you guys. So yes, TDT positive. Image was also given. 19, then BALL, TALL both were there. Okay.
Yes.
Okay, one was BALL and another was TALL, right? So answer will be BALL in this. Answer will be BALL. There was a dot plot given, that is flow cytometry given or markers given? Oh,
So
image
according
of
to
flow
the recall,
cytometry.
yes, flow cytochemistry image.
Image was given. Okay, FCM image was given. Okay, good guys. So you have made a diagnosis. Okay, 22 positive, 19, 10 and TDT positive based on the flow cytometry image. That's good. That's good.
And so the 5-year-old child, the age was also
Was
very
5 year. Okay, that's good. Yes, so I have only collected these many. Any more you want to add, students? And Dr. Shagun first, any more questions you are having, you can share.
Yes, sir. There are few match the following.
Okay, just a minute.
I'll just.
Yeah, now you can share.
Is it visible?
Just a minute.
So I've shared the screen. Is it visible?
No, no, just a minute. No, it's not. It's not.
Shagun, no. सर आपको लॉग ऑफ करना पड़ेगा संजीव सर. यू हैव टू.
अच्छा, नहीं मैंने बंद कर दिया था.
हाँ.
स्टॉप शेयरिंग कर तो दिया था.
यस शगुन,
अभी आ गया.
आ गया?
हाँ.
Okay, one of the question that I got was not a feature of meant to be. And these were the options. Those were given. And we all know that in this, we have your parathyroid hyperplasia, which is a feature of your meant to A and not meant to be. So option B is going to be the correct answer here. And Just a second. So option B is going to be the correct answer. Yes, and this we have already discussed with the factor 13 deficiency. And yes, this was a question regarding the match the following. So students, this was the recall that I've got. Please see. Are these options correct? Gaurav sir,
Yes, ma'am.
please add to it.
P10 was also there, if I'm not wrong.
Okay, P10.
Yes.
Okay, perfect. I'll add.
That's all I got, ma'am. 3 options, and fourth one was P10 with Cowden syndrome, ma'am.
Okay, so yes. Okay, so we can add APC for your FAP. APC is for the FAPs. MAD4 is your juvenile polyposis syndrome. And STK11 for Peutz-Jeghers and P10 for Cowden syndrome. Okay.
TSC was there.
More of tuberous sclerosis.
Tuberous. There was a question on, sir, there was a question on centromeric pattern
Yes,
also,
ma'am.
right?
Yes,
So
ma'am.
please
Centromeric
add.
pattern.
Sir, you share that question. I did not get the complete one. Acha, no Cowden tuberous sclerosis. Okay, so was there TSC complex given in the genes? Okay, TSC1. So, okay. So we can add TSC1 for tuberous sclerosis. This was also a question that I got. Okay, so final is APC, SMAD4, STK11, and TSC.
Yes.
Okay. And there was a question regarding this EMT, epithelial to mesenchymal transition. We always discuss in the class. That is going to be your snail and twist. That is your option C for EMT. That is for metastasis. Yeah, right. So epithelial to mesenchymal is going to be your option C. That is snail and twist. Next, please recall this question. Test that can be used for the detection of aneuploidy. And I got to know that was multiple answers. So we all know that fish and conventional karyotyping, that is option C and D, both. If this is a question for multiple answers, C and D are going to be typing. PCR and Sanger sequencing, basically we go for mutations. And if the question was particularly mentioning aneuploidy, that means we will go for fish and karyotyping. Okay, yes, perfect. Yes, fish and conventional karyotyping, collectively called as cytogenetics. Yes, yes, very good. Okay, yes, option C and D. Perfect. Okay, done. Okay, so this was there. Now, another question that
just a minute, Shagun. In this, was PCR also included in one of the combination? Because even on PCR, we can detect aneuploidy. Although we don't use it, I tell it in the class, we can detect, but we don't use it commonly.
Okay,
so
sir.
if A, C, D was also there, and if this is a question, then even A is also correct.
Okay, sir. I'll see the combination of the options.
It was
Okay,
just
done.
a combination.
Was PCR mentioned in the options?
Students, tell please, PCR was mentioned in the options in this question?
Yes, ma'am. They're writing in situ
Okay.
hybridization was there, ma'am.
Okay, okay.
Yeah,
Then,
in situ hybridization was there.
Mm-hmm.
So only thing is A, C, and D. If 3 options are given, then that is correct. Or only C and D, then.
So Dr. Nidhi is saying C and D were together only given in an option.
Okay, then fine. Because we commonly don't use PCR for diagnosis of aneuploidy, but it can detect.
Yes, yes, done. Then we can go for C and D. Okay.
All of them no. All of them no. Only A, C, and D, if it was there, then it would have been.
Okay, done. Okay, so next question, students, please recall. This was the question that I got. Match the following. One side there were cancers, and other side there were their tumor markers.
Dr. Gursimran is saying all of the above was in the option.
No, all of the above, even if it is in the option, that's not the correct answer.
Right?
Because Sanger cannot be done. Yes, sir. So if I go by this for, yes, choriocarcinoma, we are going to use your, yes, for HCC, medullary carcinoma. Was there in the question? Please recall. इसके अलावा, Gaurav sir, if you have any other.
Not really, ma'am. यही मिले थे, ma'am.
यही मिले थे तो ठीक है फिर for choriocarcinoma we are going to go for beta HCG, option B for HCC, I'm going to go for alpha-fetoprotein. For medullary, I'm going to go for calcitonin, and pheochromocytoma, I'm going to go for catecholamines. But in some students told me catecholamines ki bajay there was metanephrine. So sir, if any of these can be the option, the answer is going to be the same, right?
Yes.
So this was the match the following that I've got. Okay, it was hepatoblastoma. Okay, again, the answer is going to be the same.
Same.
If not. Okay, all options rightly mentioned. Okay, so we will change to hepatoblastoma.
HCC to hepatoblastoma. Answer remains same.
Okay, done. Perfect. Yes, Abhishek, absolutely correct. Chalo. Yes, this was a straightforward question. So please tell me a favorite question regarding sickle cell anemia, straightforward. The answer is going to be here in this case, option C, that is glutamic replaced by valine at beta 6. Okay, Sakshi, if metanephrine is there, the answer is going to be the same. Okay, so glutamic replaced by valine at 6th position of beta globin chain, option C here.
Yes.
Yeah, Dr. K. Keswan, ma'am, there is one more question on the earliest test to diagnose pheochromocytoma.
Okay, so I didn't get that question. So, sir, please.
Students, am I right? There was one more question on the earliest diagnosis for pheochromocytoma. Can you recall the options, please?
No, earliest investigation probably, and that will be more of surgery question.
Okay. Okay, sir. This we have discussed already for HbA1c. This also we have discussed, Leiden. This also we are done with. Yes. This is a combined...
just Shagun, question I think was glutamate replaced by valine, and what is it? The reverse of this question.
Okay.
So they had given the pathology, glutamate is replaced by valine, and what is the HBS, HBC would have been option.
Okay. Done,
just
sir.
change that.
Okay, we will change it. Okay, done. So that is going to be HBS.
Was that the correct question? They had given 6th position, glutamate replaced by valine, and what is it? That was the question, right?
Yes. Valine, that's Dr. Nidhi is saying valine to glutamine mentioned, only HBE transition mentioned correctly. Okay, valine to glutamine was mentioned. Yes, sir. So
that was in the question, right?
Yes. It was mentioned in the question.
Oh, not in the question again. So there were...
Ilma, was it mentioned in the
question?
or in the option?
Please tell us what was the question. Question was like this, framed like what is happening in sickle cell anemia. Okay, they were in options. Only thing is, okay, they are talking about 26th position. Okay.
Okay.
Got it. Question remains same. Only thing is, option is 26th and 6th position. Yeah. 26th position, glutamate to lysine, that is HBE.
Yes. Okay, done.
HBE question was there, ma'am.
Okay, so one more question. That's a micro patho combo. Match the following. You had to mention the bodies. So this was also PYQ, Parkinson's, Levy. One is C, myeloma. We see Dutcher bodies.
Shagun, I'll just take a moment. I think, first of all, I would like to congratulate all the 3 faculty members on the screen. आप लोगों ने, आई थिंक वी कैन ऑलरेडी सी दी स्ट्राइक रेट. इस बार सेकेंड ईयर के सब्जेक्ट्स बहुत आए हैं. आई थिंक डैम्स की सेकेंड ईयर टीम बेस्ट है. एंड आई वांट टू कंग्रेचुलेट ऑल ऑफ यू, डॉक्टर संजीव, डॉक्टर शगुन, डॉक्टर गौरव, ऑल ऑफ यू ऑन द स्क्रीन. आपने बहुत बढ़िया पढ़ा है. मेरे को बहुत सारे बच्चों के मैसेज आ रहे हैं, यू हैव डन वेरी वेल एंड ऑसम. अब मैं रिक्वेस्ट करूंगा सभी लोगों को, चैट बॉक्स में भी बच्चे जो भी हैं, कि दे हैव प्रेडिक्टेड एवरी सिंगल क्वेश्चन हैव कम फ्रॉम देयर क्लास नोट्स. बहुत बढ़िया. तो व्हाट इज योर ऑब्जर्वेशन अबाउट द पेपर? पेपर कैसा आपको लगता है? क्योंकि मुझे लगता है हमारे तो शॉर्ट सब्जेक्ट्स इस बार कम आए, सेकेंड ईयर बहुत आया आपका. तो आपका, मुझे लग रहा है आपका हीमोग्लोबिन काफी हाई होगा इस समय. तो कैसा फीलिंग आ रहा है आपको?
सर, ऑलवेज एज यूजुअल INICET और इवन नाउ NEET PG ऑल्सो ना, तो दैट विल
डेफिनेटली. एंड डॉक्टर गौरव, आपको कैसा लगता है?
सर वही सर, हीमोग्लोबिन अभी आप चेक कर लो, ज्यादा ही मिलेगा सर. So the platform that you give, we make sure, sir, payback time, sir, and we think we have done really well, sir. Questions हमें, I think Shagun ma'am and Sanjeev sir will agree, कुछ भी ऐसा नहीं लग रहा है that we are amazed कि मतलब ये नहीं था sir. Everything is there, sir. Very happy to see the results, and students, the overwhelming response is really good, sir.
And I don't think in the entire country there's a better pathology team than which is sitting in this on the screen with me right now. ये तीनों लोग मिलके I am sure आग लगा देंगे, और कोई भी ऐसा एग्जामिनर हिंदुस्तान में नहीं है जो इनके बाहर सवाल पूछ पाए. So awesome. And I will just request you to continue your beautiful discussion. I'll just go out of the screen, but I wish all the best to all the aspirants. याद रखना बेटा, अपना टाइम अपन खुद लाएंगे.
Thank you so much, sir. Thank you so much.
Really means that, sir. Thank you so much.
Thank you, sir.
Sir,
Thank you.
one thing I really want to add, since afternoon, I'm getting these messages only that Mission INICET, Pathology, DAMS, everything was from notes. So yes, it gives a very, very happy feeling. I hope sir, Gaurav sir and Sanjeev sir would agree with me on this.
मैम आपका फेस हम दोनों की हैप्पीनेस एक्सप्रेस कर रहा है. आपका ही
Yes.
बहुत है मैम.
Yes, yes,
Really happy to see the response, मैम.
yes.
देखो मैम क्या रिस्पांस आ रहा है, ऐसा लग रहा है डैम्स के पैथो टीचर फैकल्टीज ने पेपर बनाया था.
अरे बिल्कुल.
Great ऑफ मैम.
अरे गैस्ट्रेक्टमी वाला भी क्वेश्चन आया. I forgot that. अभी
हाँ,
है?
yes sir.
हाँ.
Yes, sir.
Okay, okay. You can just share that. See, देखो क्वेश्चन तो सारे नोट से ही आए हुए हैं. I mean, looking at the options as well.
Yes sir. मतलब
And TND. I mean, that was my favorite question in TND about the blood collection.
oh.
आप लोगों ने गलत किया था उसको. मतलब मैंने क्लास में बताया था, इफ एनीबडी इज फ्रॉम TND बैच हियर, मैंने क्लास में डिस्कस किया था कि ऐसे क्वेश्चन आएगा तो फंस जाओगे. तो टॉर्निके वाला और हैंड शुड नॉट बी फोल्डेड आफ्टर कलेक्टिंग द ब्लड, ये सब बताया था क्लास में.
अच्छा लगता है सर ऐसा, जब एक बताया हुआ क्वेश्चन आता है तो और अच्छा लगता है.
और बताने का मन करता है.
हाँ. Chalo, this was a question we were discussing. We had to match the bodies. So for Parkinson's, it's Levy body, myeloma, Dutcher bodies, malakoplakia, Mickless.
Again, I think you have to share the screen.
Okay, sir. Is it fine now, sir?
Yeah, now it is coming.
And for rabies, yes, it is your Negri body. I hope the options are correct. Okay. So I got to know there was a question on celiac disease as well. The question was asking not true about celiac disease. The false was being asked. So if I go by ruling out as well, so anti-gliadin antibodies present, that's absolutely true. TTGA antibodies present, IgA type, true. Marsh criteria, yes, it is used for diagnosis, but we always say in the class, it is HLA-DQ2 and HLA-DQ8. So the option that is going to be answered here is going to be option C. It's not DQ6, it's DQ2 and DQ8. I hope this was there in the exam. Students, if there is anything else, please add to it. And this was the celiac question. And I got to know there was a question on schwannoma as well. So please correct me, students, if there is any change in the option or the image. As far as I got to know that the question was that which of the following is not true regarding the tumor shown below. There was an image of Verroque body schwannoma. So if I go by that, if I go by that question, option A, Verroque bodies are seen. Yes, that's true because this is going to be a schwannoma case associated with neurofibromatosis. Absolutely true. It originates from the cranial nerve sheath that I got to know. So that's also true. Malignancy is common. I think ruling out the options.
Metastasis was in the option, ma'am, as far as I know.
Okay, sir. Malignancy.
The correct answer, the wrong answer, ma'am.
Yes, that is going to be the answer here. Then option B, sir is saying malignancy with metastasis. So is there anything else? Okay. So history mein tha that tumor in the forearm. Okay, we will add it in the history. Okay. It's a forearm mass. Okay, originates from the nerve sheath. Okay. Metastasis. Okay, so correct answer is going to be your malignancy with metastasis common here. And the diagnosis is schwannoma. Okay, correct, guys. Okay, students, we have made a point here. We have or you want to change here. So we have to match the inheritance. So we all know DMD, Duchenne muscular dystrophy, is your XLR. Marfan is your autosomal dominant. cystic fibrosis is your autosomal recessive, and optic neuritis is your mitochondrial inheritance. So one was the syndrome and diseases, and another we had to match the inheritance options here.
Students, if it's optic neuritis or List-Nayan syndrome was in the option? Oh, sorry, Leber's optic neuropathy?
Yes, please recall and tell me, students. So was it optic or it was particularly Leber's? The answer is going to be mitochondrial
And the
inheritance.
same only, but just to know the exact options.
Yes, yes, sir. Okay, okay, it was Leber's.
Yes, ma'am.
Okay, some are saying lawn. Okay. Leber's was there for mito. Okay, perfect. That is even more better. Okay, we will change it to Leber's. Leber's hereditary. Okay, perfect. So this question we have already discussed. The answer is going to be BLL. So that is from my side. Gaurav sir, if you have any other questions,
Ma'am, I think
please.
we have covered almost all question. Only one question. All of the following is feature of Carney's complex except. I think that is the only one missing. Rest you both have already discussed all the questions, ma'am. Two
Okay.
questions.
So please share the screen.
Yes, sure, ma'am.
I'm just a second. I'm leaving. Yes, sir. So you can share the screen now. Okay, some students are saying Marfan was not in the option. So what was there?
That's all discussed. What is discussed? Guys, if I'm not wrong, I heard there's a question on the image-based question on testicular tumor, embryonal cell carcinoma. Is it right? It was more of an image-based question. Kindly respond, students. Not very sure about this. They said image-based question was given, ma'am. A 33-year-old male with testicular mass, and I think CD30 was also in the options.
Okay.
And gland formation was that in the options, guys?
What was the age?
So I heard just not much history was given. It's an image-based question on embryonal cell carcinoma testis.
Yeah, 30 would be.
No.
And
no, sir. More
it is
options are
like
going
this.
No, sir.
There was no such question.
Okay, sir. Okay. This question. Not the part of Carney's complex. This was the options, right? This is the question, right? On this. Not the part of Carney's complex. So there were three options given. Not on Carney's complex also? That is for sure. 3-4 students told me this thing. All of the following are part of Carney's complex except. Okay, so corpora amylitia was given in the. Okay, no problem. So if there was a question on this, name absently.
Yeah, there was a question.
Okay. Got it. Not a part of, yes. Okay, done.
And one more question.
Anji sir.
One more question was a post-gastric. I think somebody is here.
So there was a question on Carney's complex and there was absent anomaly in the option, is it? Question was this only, not the part of Carney's complex, is it? Okay, great, thank you. So there was a question, sir. All the following is a part of Carney's complex except, and as they're saying, name the syndrome. They gave an option and you have to name the syndrome of Carney's complex.
No. Name NME acronym.
Okay. Done. So let's talk this ma'am discuss, man syndrome ma'am discuss. Covered, sir. All the questions have been covered by you. I was only confused about this question, sir. That's all is covered, ma'am.
Yeah. So I think the last question was that as well. That is gastrectomy, neurological manifestation, B12 deficiency.
I thought this was an option. The vitamin deficiency caused after ileal resection was given. Gastrectomy was in the option.
Yeah. Gastrectomy.
Okay, sir.
I think you are echoing. You
Done, sir. Done. We are done, sir. So we can finish our pathology recall session, sir.
Okay, guys. So this was from pathology department here. There were I can count 22 plus questions. Probably we'll have to just I guess. So we have questions and rate 100%. We are talking rate of 100%. Best wishes. Now I will request next faculty.
Thank you, students. Thank you for the all response. Thank you, sir. Thank you, ma'am.
Thank you so much, students. All the best.
All the best, students.
Okay, so good evening, all of you. I hope your paper was well. There were very, very limited questions from dermatology, and I think I got just a 4 question. Just give me a quick thumbs up if my audio video is all going smooth. I just need a quick thumbs up from everyone. Great. So without wasting my time and your time, I'm just sharing my screen. Just give me a second. Yes. Okay, so let us discuss the first question which we got from this. The first question was the whiff test is positive in. I think already Deepthi ma'am have discussed this question. It's a very, very easy question. And we have a very similar kind of question in the INICET which happened in this year in the May or June. So in that test, they have asked about this particular criteria. What is amine test? What is EMCELS criteria? And this time they have asked you that whiff test is done. So please remember, I think it's a very simple question. It's a feature of bacterial vaginosis where you put KOH in the vaginal discharge and it produces a very foul, fishy smell. So the first question was very easy from dermatology and it was a direct repeat from the last year. So, okay, fine. Great. Now coming to the second question which I got from the students. Now this is again, I'm not very sure these were the options, but if these were the options, it is again a direct question from the last year INICET or last to last year INICET. The question was urethritis in men can be due to all except. So urethritis, you all know that urethritis, the STD causes can be divided into gonococcal and non-gonococcal. The gonococcal causes is because of Neisseria gonorrhea. Non-gonococcal causes could be chlamydia, which is the most common cause. Second is you have mycoplasma, ureaplasma, and you have trichomonas vaginalis. Now, please remember, among the options provided, Haemophilus ducrei never causes urethritis, whether it is male or female. Please remember that Haemophilus ducrei is the known cause of chancroid, and it causes genital ulcer, painful ulcers with associated painful lymph node. Okay, so there was one option as mycoplasma. So mycoplasma is also one of the cause, although not very common. It is also one of the cause of urethritis. Fine. Okay. So that was the second question. See, if Haemophilus ducrei was not there, now if you have to pick, obviously, you have the cause as the Neisseria gonorrhea is one of the common cause. Trichomonas vaginalis is the common cause. Then mycoplasma will be a common cause. I would say the Gardnerella would not be a better option here. Yes. So the fourth option, okay. Okay, so everybody is saying that Haemophilus ducrei was not the option. Mycoplasma do causes the, do cause the urethritis, whether it is male or female. Okay. The third question which I got was, which of the following is not a like how will you differentiate psoriasis from other arthropathies? Now, please remember all of you, psoriatic arthropathies, it do have associated pitting. And in fact, pitting is seen in majority of the patients. Enthesitis is also a feature. Dactylitis is also a feature, but please remember diarrhea is not the feature of psoriatic arthritis or psoriasis in general. Okay. Yes. So please remember here the answer will be option number 4. In psoriatic arthritis, we do see other features except diarrhea. Diarrhea is not a part of psoriasis or psoriatic arthritis. So the answer of this question becomes option number 4. And this was the last question. Which of the following causes infection due to barefoot walking? Now, I just got 2 options. I'm not very sure what were the other options given. So the answer which I prefer here would be Madurella mycetoma. Okay. The answer of the previous question would be Gardnerella. Yes, the Gardnerella would be the best option for urethritis in the male accept question. Yes, Gardnerella should be the best possible answer if instead of Haemophilus ducre, Mycoplasma was given. And for this question, can you tell me what can be the option number 3 and 4 so that we can have more discussion? Because if nocardia and Madurella was given, you know that Madurella mycetoma is one of the common cause of subcutaneous fungus. And subcutaneous fungus, you find them more in the soil, and people who barefoot walking or who do like farmers and gardeners, they're more common to get these kind of infections. Now, Madurella is more common in the foot because of barefoot walking. So, okay, another option was Aspergillus here. Other option was Aspergillus, and one of the option was Curvularia. Then again, the answer remains same if the Aspergillus curvularia was the option. Sclerosis question, I have not got. Only these 4 questions I got till now. If you have any more questions, please try to put it on the chat section. If it is coccidioides, again, barefoot walking, Madurella would be my first preference. If you have to pick from all the other options, Madurella mycetoma will be my best possible option if I have to mark one. Now, one of the students is saying that sporothrix was also there. Now, even if the sporothrix is also mentioned in this particular question, and if I have to choose between sporothrix and Madurella, please remember that Madurella mycetoma is common on foot compared to that of sporotrichosis, which is more common on the hands. And that is why we call it as Rose Gardner disease. Because of the prick, you tend to get the lesions more on the upper extremities like hands or the forearm. So even if sporotrichosis would be there, my preference would be option number 1, Madurella mycetoma. Systemic sclerosis, was there any question? I have not got that question. Can you just write that question in the chat section so that I can just go through them? Okay. Sporothrix was a different question. Okay, we have another question of sporothrix that I didn't get. So sporothrix, I think you know it is a subcutaneous fungus where you see the linear lesions. There is a linear spread of the nodules or ulcers. And the reason for the linear spread is because the sporothrix chancre, it enters the lymphatics and it spread from one place to another place through the lymphatics. So that is the reason. Fine. Sporothrix is the second question. Great, great. So I think these were the 4 or 5 questions. Like I was aware only about the 4 questions. You told me one more question was there from the sporothrix. I think that was another question. So 5 questions till now. So I have only these questions and I think they were very easy. If anybody has to attempt dermatology question, I would say it was very simple. So 5 questions from dermatology is good enough. In general, we have very less questions from the short subject. So I think if you get more questions, keep posting. I'll be checking the chat section. And I think now I'll be stopping my session because we have other faculties waiting. Yes, okay, okay. So thank you all of you. And I'll request, I think Saurabh sir or Tiru sir, Surya sir, please take the session.
Hi चेष्टा, very
hi,
well
ma'am.
done चेष्टा. बहुत मैं देख रही हूँ कमेंट्स, बच्चे बहुत ही खुश हैं. So you know, good job done. And I think as a team हम लोग we are all putting in a lot of effort और बच्चे भी बहुत मेहनत कर रहे हैं. तो may God bless everyone and everyone should come out with flying colors.
Yeah, yes, ma'am.
चलो, good job, good job.
Hello, good evening to one and all. Hope my video, audio, everything is okay. I start from derm. Dermatology, the last discussion was sporothrix. I start with sporothrix. Okay, because it's integrated session always. We got a question. People already mentioned Rose Gardner with injury. Okay. And this picture they mentioned. I got this picture. Many kids are so happy. They send it to my Telegram group. Sir, the same picture came. You know where the picture was there? It was in the workbook. See the workbook picture evidence. The workbook, what picture we have made, same picture came in the exam. After seeing that, many kids got excited. So it is identify this Rose Gardner with the axillary spread, lymphocutaneous spread. Then it is sporothrix. I don't know the other options, but everybody says the correct answer. Instead of other answer, everybody says this is the correct answer. Okay, I made some video also. Astronaut from Mars, like I wear astronaut dress, artificial intelligence. We made some fun with this fungus, but it is not fun. It really came finally. Great. Okay, nodal ulcerative growth. Yes, all the points we have discussed. Cigar shape yeast, floret shape mold, asteroid body, lymphocutaneous spread. Just 4 points over. Exactly the same picture. Yes, my dear, it is from the workbook. Exactly the same picture came. Because we select lot of pictures and we give the best picture to you. The same thing the examiner also did. Nothing surprise. Yes, Dr. Shaila Healthcare, exact same picture. Kavya Somanathan. Yes, I got the feedback. Picture, put the picture. They got excited. Sir, exact picture came. Good. Second question is waterborne hepatitis. I used to say vowel and bowel. A and E are waterborne hepatitis. The direct question. A and E, vowel in bowel, are waterborne. B, C, D is bloodborne. This thing. A is the answer. Very easy question. Very easy question. Oh, okay. Sir, workbook was 100%. Thank you, Shubham Rahul. Histoblast our other options. I will write now itself because tomorrow I'm going to give a full version. Blasto, any other option is there? Thus I will fill it. Thank you. Okay, now I'm getting material from you. Before exam, you get material from me. Okay, vice versa. Good. Good. Waterborne hepatitis. Next is medium for Mycobacterium tuberculosis. Solid medium, known medium is LJ medium. Everybody know the correct answer. They forget about the wrong answer. No, nothing wrong in it. Forgetting wrong answer is not a sin. Okay, everybody says LJ medium. Other mediums. Coccidius is the other option. Very good. Coccidius. I'll fill it. No problem. Microvasit fire. Great. You rock always. Thank you. Medium for Mycobacterium tuberculosis, LJ medium. It takes 6 to 8 weeks growth, rough, buff, tough colonies, everything we have discussed. Great. Pus from wound, gram-positive filaments, partially acid-fast, growth from pus culture. What else you need? I used to give only 4 points to 5 points, nocardia. All 4 points in the exam they asked. Partially acid-fast, growth from pus culture, gram-positive filamentous, aerobic, exogenous, that's all. Other options, anthrax and listeria. You can go for nocardia. Partially acid fast, always nocardia. Okay. SDA. What medium? Something they asked. I don't know about medium. Yes, 200 questions made ultra age. Great. Next is, it grows in which medium? Okay. Next is, which is not a cold sterilization? I didn't get the full question. See, cold sterilization is gamma radiation. Gamma radiation. Otherwise called gamma radiation. Otherwise called ionizing radiation. I don't know whether they ask cold sterilization or which is not cold sterilization. Okay, plastomyces was in sporothrix. I will write, my dear, no problem. Gayatri, I will take it. UV radiation. Plasma. Yeah, these all we can consider as cold, except autoclave. Autoclave, we are giving 121 degree. 121 degree, 15 pounds per inch square. Okay, not cold. Not cold is autoclave. Among the choices, autoclave. Gas, plasma, everything is. Autoclave is totally hot sterilization, no problem. Okay, we commonly call radiation as cold sterilization, gamma radiation. Okay, but among the choices, best is autoclave. Autoclave, great. Gas, plasma, I got all the options to you. Thank you, good. Drug of choice for facial hepatica. Usually I used to tell, this is my slide. Evidence. Trematodes, I used to say all trematodes praziquantel, facial hepatica, trigylbendazole. And see this, I taken from video, just I recollected the video. This is the video. Just 2 minutes video. That's called parasitology, bugs versus drugs. Bugs versus drugs. Yes, Dr. Kaur, which is not cold. Okay. Previous question, blunt injury from the farm instrument. This one. Okay, blunt injury. From farm instrument. Very good. I will write the story. No problem. No problem. No problem. Okay. See carefully here. Drug of choice for facial hepatica is, what is it? It is tricalbendazole. We specifically mentioned all cystodes, praziquantel, neurocystis, sarcos, albendazole, all trematodes except facial hepatica. Okay, albendazole, mebendazole. Albendazole, mebendazole. Anything praziquantel is there? If praziquantel is there, it's a close combination, because praziquantel also is a treatment for a facial hepatica. Great. Then praziquantel also a treatment for facial hepatica, but first line drug, special drug of choice is tricalbendazole. Okay, right. Next is Ascaris lumbricoids not associated with. I don't know about the other condition. It associated with low flux pneumonia. It associated with intestinal obstruction, many things. It is not associated with among the choices. I got the question, choice is rectal prolapse. Rectal prolapse commonly seen in trichuris trichura. I don't know about other choice. If I have the other choice, I may change the option, or the better choice is there, I can go for the better choice. Prasi was there. Great, 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 great. Ascaris lumbricoids not associated with asthma-like symptoms, definitely. Like symptoms. I will write the notes very fast. Okay, asthma-like symptoms. Low flux pneumonia is there? Anything? Asthma-like symptoms, low flux pneumonia, or any diarrhea, intestinal obstruction. Lung wall option is there. Yes, everybody says asthma-like symptoms. I didn't get other choices. No problem. Definitely not rectal prolapse. Rectal prolapse is associated with trichuris trichura. If anything unique, you people remember. If it is not unique, you won't remember. No problem. Okay. Next is antibiotic sensitivity testing. We can go by rule out method. Okay. Yes, unmembranated eggs released, which converted embryo, which is infective, right, Agil? Agil. Okay, right. Soil egg, that everything is right. except it won't cause rectal prolapse. Okay. Soil egg conversion. I will write the notes. After that, I can mix. Eggs are uninfective. Okay. Unimmunized takes some days for, yes. E-test. Because CAMP test is for group B streptococcus to diagnose. LX gel, Corynebacterium diphtheria toxin. This is antigen antibody reaction, latex agglutination test. You can easily rule out. E-test, epsilometer test for antibiotic sensitivity testing. It's a form of disk diffusion method. E-test, epsilometer test. Epsilometer test, very good. So antibiotic sensitivity testing is epsilometer test. You can approach rule out method. Rule out method. E-test is for rule out. You know CAMP test, you know LX gel, you know latex agglutination. All three are in my notes. Based on that, easily you can rule out. Good. So nice answer. Fertilized unembryonated. Take time. Okay, good. Next is true about Cryptococcus. True about Cryptococcus. Extra pulmonary Cryptococcus is AIDS defining illness. True. Cryptococcus gattii sources from bird, soil, eucalyptus trees, many places, different areas. True. All are urease positive. See my notes, I write Cryptococcus neoformans, all urease positive. These three are true statements. Okay. CD4 more than 500, no need. It can affect CD4 less than 100. CD4 and disease is around 100. When it is around 100, we can expect cryptococcal meningitis. Cryptococcal meningitis. All are true except. So true means 1, 2, 3 are correct. Or ABC are correct. I don't know how they formed the question. ABC are correct. Not true about Cryptococcus. D is the answer. That means question is not true about means I marked correct one. I marked correct one. Good. Easily you can make it. Because cryptococcal meningitis, AIDS defining illness, it's extrapulmonary. See that my first line notes is it is seen in nitrogen-rich soil, bird droppings. And before finishing the treatment, I start my notes, you see urease positive. Okay, right. Except, good. Wire loop is sterilized by. Wire loop usually sterilized by hot method, heat method, dry heat. Dry heat by dry heat. Red heat is in the lab. In the lab used to do red heat. Not true on multiple choice. Okay. Red heat. Heating till red hot. Basic. Wire loop sterilized by. This will be present in my back to basics, not in regular. Wire loop is, you can rule out other methods. Some questions you can go for rule out. Okay, right. Flaming till red heat. You mark, then you are right. Whoever mark till red heat, Abhishek Roy, Tawhid Maman, all right. You packed on question, don't worry. Apart from that, match the following question. One question is there, match the following. Disease, now I got it in my Telegram group. So I wrote it in my hand instead of typing. Tomorrow I'll type and give the full form to you, full version to you. Match the following Donovanosis. So here microwave was the option. Good. Microwave. Okay, right. I will do this. Don't worry. So Donovanosis usually Klebsiella granulomatis, Oroyo fever, Botanola bacilliformis, where rat bite fever, Streptobacillus moniliformis, Pinta Trypanoma caretium, Pinta Trypanoma caretium. Very good, very good. Autoclave also there. Good. I'll write autoclave. Autoclave, microwave, red heat, not here, head, red heat, or heating till.
Hi, sir.
Hello.
Hi, sir. So I just thought I'll just quickly drop in, and I think once we have a full screen there. So thank you, sir, for an excellent coverage. Students are very happy from your back to basics and the regular classes. This year, I think second year subjects, microbiology, pathology have ruled the game, and DAMS faculty members have a massive strike rate. Dr. Surya, you have done a
Thank you, sir.
fabulous thing, and I can see your hard work in your recollection also.
Thank
I
you.
know how much you are traveling with the lectures and everything, but still your recall is immaculate, sir. Thank you.
Thank you, sir. Thank you.
Thank you.
Last question. Necrotizing fasciitis, especially already injured skin. The clue is injured skin. Please remember, necrotizing fasciitis caused by flesh-eating bacteria. Most common is Streptococcus pyogenes. Whatever other option, don't worry. Go for Streptococcus pyogenes. The predisposing factor is infection, already infected skin. Already infected skin. Okay, necrotizing fasciitis. And one more question I got, aspirated fluid. Some images there. People thought it is hydatid cyst. I will get back to you with the full version. Then it's a hydatid cyst, aspirated. Okay. Skin. And now you can see the screen. Okay. See, necrotizing fasciitis, injured skin. Injured skin. Go for Streptococcus pyogenes. Streptococcus pyogenes, chain of cocci. I'll write another one. Chain means go chain of cocci. Even without chain of cocci, the most common is Streptococcus pyogenes, necrotizing fasciitis. I give the mnemonic. Remember, NICE, necrotizing fasciitis, impetigo, cellulitis, erysipelas. I put the nice biscuit photograph also to you people. Hope you people understand. Okay, now I'm sharing the screen. No problem, ideas. And one question, aspirated fluid, some images they mentioned. I will get the full image. I'm asking some kids. Okay, that image is almost look like it's a scolex. It may be hydatid cyst. Okay, and some questions are just overlapping with the PSM and other subjects like malaria diagnosis in field, which is best, and copper T, which color coded bin you are going to put. This just overlapping this thing. I don't want to do surgical strike. Anyway, I'll come with those questions tomorrow. No problem. No problem. Okay. Cystic sarcosis, echinococcus, granulosus. One more was there, sir. Great, great, great. I will get the thing tomorrow. Don't worry. I'll get the full things. Okay. Many scoliosis. You can think of scoliosis with rostellum. You can go for cystic sarcosis. Okay. Only small 3 pieces. You can go for echinococcus granulosus. I will get back to you with correct picture. Upper right quadrant liver. Always you remember it is echinococcus granulosus. Close the file. Okay. So other faculties are waiting. Thank you very much. I'm so happy. Full strike rate. You can answer all the questions from micro. Really, I was worrying how my kids are going to do. I'm really praying like how my son is going for exam like that. Really, you people did well because of seeing the question. I'm so happy. I'm getting excellent feedbacks. Thank you. I'm now signing off and I'm stop sharing my screen.
All right, thank you, sir. Hi, everyone. I hope I'm visible and audible to you. Surya sir, am I audible?
Yes, you are audible. You are audible. You are
All
audible.
right, thank you, sir. So I hope you have given the exam well. And it's time to relax. Not for the NEET exam, but at least you can relax now. You can take 1 day break. Try to relax. You have done your part. and it will be good. So it's time to relax. So let's start ophthal questions, and there are so many questions in ophthal, and I don't know. I think some retina specialist has framed the question. So many questions have been there from retina. So if you have done one chapter from retina, then you must have solved many questions in ophthal today. All right. Hi, Abhishek. Thank you very much. So let us start the first question. And see, what was the trick in this question? A patient came with the chemical injury. Now, this is a repeat question. What is the first step in the management? In that previous question, history taking was not given. And if history taking is not given, of course, the first option is copious irrigation with water saline. Now, in this is the INICET. They want you to apply a little bit of common sense as well. So if there's a little bit of common sense, how will the doctor come to know it's a chemical injury? Now, student says it was written in the question. Are you know it is in the MCQ? How will the doctor know it's in the MCQ or not? It's in the patient's eye or not? So patient will tell because doctor will ask, what is the history? So of course, history taking should be the first. No, Gayatri, madam. History taking is first. How will the doctor know whether the patient is having... so that is why INICET, you can't just... It's not PYQ like this. You have to see PYTs. Unless some little bit of thing is required, common sense, that patient, doctor will come to know about the chemical injury when he will ask the patient. The first thing is history taking. Then you do copious irrigation with saline, slit lamp examination, to take visual acuity, whatever. All right, I think these were the 4 options. I've got many options. I've been recollecting the options. I think this was a... so Sakshi came after hours or minutes or days. The first step is doctor will ask the history, na? So that's why they want you to apply a little common sense. I think options were okay. But Death Punch is saying damn. Damn ni dams. Okay, I think there's no doubt in that. History taking is the first. The second question, there are about 13-14 questions, okay? Abhishek Roy, aisa nahi karna hai. Which of the following is true regarding viscoelastics in cataract surgery? Let us know the options. I've got the first option, damage to corneal epithelium. So if it is damaging the epithelium, why will use in the cataract surgery? This is again a common sense. It is inert, that's why you're using it. It can be left in the eye. So if you leave it, see, why do I say in the 9th step of eco-emulsification in the class, visco removal? You can't leave. If you leave the bow stop there, the pressure will be high. And see, the viscoelastic is to maintain the anterior chamber before capsular excess step. So again, a direct question. This is the answer. C is the answer of this question. All right. And SF6 perfluoro are not used in cataract surgery. They are not viscoelastic. They are used in retinal detachment surgery. So answer is option number C. I hope I am giving the same options which I have got from you people only, because मैंने तो exam नहीं दिया ना इस बारी. You people are giving the exam. Silicone oil, okay, fine. Silicone oil, that is also used in retinal detachment surgery. Cause है नाम बड़ा अच्छा तुम्हारा cause है खुशी शर्मा, तुम खुश हो रही हो या रो रही हो? कैसा इमोजी है? Yeah, Abhishek, very good answer. I think this should be okay. The second question is okay. I go forward, okay? There's so many people are waiting. So let us do quickly, because these are just to recall. The main thing, I will do it later once. Okay. So which of the following is seen in a patient of diabetic retinopathy? So diabetic retinopathy, so many retina questions are there. A diabetic retinopathy, myopia, tractional retinal detachment. What is the Zenith? Zenith, what are the options? I think this is, of course, in tractional detachment, the most common cause is a diabetic retinopathy. Answer is tractional retinal detachment. I hope the options are correct. Posterior staphyloma is a hallmark of high myopia. Retinoschisis, splitting of the retina. So answer is has to be yes, Zenith, very good. Tractional retinal detachment. This should be a short question. You should got it wrong. Okay. Okay, I go forward to the 4th question. Any doubt in this? Let me know. Again, a simple one, a pterygium. Yeah, okay, good. Very good. Myopia progression was there. Okay, fine, good. Thank you very much. Myopia progression. That's why myopia doesn't make sense. Myopia progression, that is also not the answer. Okay, good. Pterygium causes what? Pterygium purulent tissue. It's not an infection. It does not cause some retina problem. It is a painless. So the most common, what is the most common cause of decreased vision is corneal astigmatism. It causes astigmatism. It's the most common cause of decreased vision. Is this the option? Rushikesh, what was the question? Question was, which of the following is seen in diabetic retinopathy? That was a previous question. If this was the option in the... Yeah, fine. Everyone has got this correct. Very good. Not a retina question, a conjunctiva question. Everyone has got this. Khushi, okay, fine, good. I think it should be straightforward. Now, there are two school of thought in this question. Identify, some people say, sir, image was there, some say image was not there. I think image cannot be there. See, if the image of this angiographic picture was asked, why will they ask this? It is already this dot, dot, dot. At least after the MBBS, they expect you to differentiate between a dot and a line. If they're giving dot, 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 answer of course will be dots. So I don't think so image will be there. I just confirmed in my group also, no image was not there. Because if image is there, already dot is there in the image. So microaneurysms are what? They are causing hyperfluorescence dots. Hyperfluorescence dots, not hyperfluorescence dot. Yeah, image is not all. It cannot be there. Image cannot be there in this angiographic picture. It cannot be there. Yeah, of course. But it is outpouching. It causes hyperfluorescence dot. I hope you have got this question correct. Hyperfluorescent dots on angiography. Good. Sixth question. Which of the following is not derived by neural crest? So many times I have told in the group and in the DAMS group, in my group, how to remember the embryo question. Neural crest, I always remember it is by so many things. Students say, sir, how will I remember so many things? I tell not to remember. You remember SLE, surface ectoderm. You remember ROMES. That is today's answer. R, retina. Retina pigment epithelium is formed by ROMES, retina. Retina is formed by neuroectoderm. And third was MESO, mesoderm. So surface ectoderm, SLE, ROMES, optic cup, mesoderm. Exception is neural crest. And that was today's question. Exception. RPE is derivative of, yeah, by ruling out the next one. Excellent answer. That is by rule now. MCQ is a game of 3, not 4. Good, Tanish. Answer is RP. Any layer of our retina is formed by neuroectoderm. Good, Mitu. Okay, now some say animation picture was asked, some said histopath was asked to identify the layer. Now, which layer was there? Nobody told. Some say it was an outer nuclear. Now, I tell in the class in my workbook, see, these are the 10 layers of the retina. You have to identify in the animation as well and histopath as well. I think they asked animation. Now, which layer was asked? I don't know. But you should know how to remember the layers of the retina. This is from the class. Now, which layer was asked? It was an outer nuclear layer. Some say outer nuclear. Outer nuclear is what? Outer nuclear is the rods and cones. If the nucleus of the rods and cones are masked, it was a outer nuclear layer. Yeah, Devashish, you can say that. Yeah, options were these, but which was a marked, I don't know that. Some say it was the outer nuclear which was masked. That's the nucleus of rods and cones. So that can be the answer. Good, Abhay. RP, outer nuclear, inner plexiform ganglion. Yeah, same sequence. Good. Okay, fine. I think this should be okay because this was a marking and you should know the marking from the histopath or animation. This is discussed in the class. How to tell in animation as well. Now, lumen of the optic artery and the vein in optic disc. What is the answer? Answer is artery and the lumen ratio. Artery lumen is smaller than the first page of the retina topic. The first page of retina topic is arteriovenous ratio is 2:3. The lumen of the artery is narrow than the lumen of the vein. And that is mostly seen in the optic disc. Okay, so that's the answer. 2:3 is the ratio, normal arteriovenous ratio. Okay, Tulsi, I will say that. Okay. Yeah, Zenith, J. Goel, Abhishek, good answer. This was, I think, a straightforward. And hypertension, it is 1:3. Normally, it is 2:3. Now, which is the investigation of choice of Best disease? Now, Best disease is what? RP layer. Again, a retina question. RP layer dystrophy. In RP layer dystrophy, the electrooculogram is investigation which is reduced. And this was first for Best disease only. Electrooculogram tells about the rods and cones and the inner bipolar cells. Electrooculogram tells about the RP, and that is dystrophy, Best disease. Electrooculogram is the answer. I hope you have not marked multifocal electro. I think retinogram was there. Multifocal electroretinogram, ERG. Multifocal. D option, I don't know. What is the D option? Anyone? VEP. Okay, fine. Visual evoked potential. No, that is 124 milliseconds. The impulse from the retina to the brain. Gayatri, hyperfluorescent microaneurysms. Now, Arden's ratio is seen in electrooculogram. J. Joel. So, answer is electrooculogram. Good, Kushali. Okay, fine. I've marked visual evoked potential. I will mark. Thank you very much. The 10th question is again ruling out the option sudden and bilateral. So, I think one was this was acute congestive glaucoma. Now, acute congestive glaucoma cannot be the answer because it is a painful condition that is causing pain. Even iridocyclitis can have a little bit of pain. It is sudden onset, but pain is there. Keratoconus is not sudden. So what is left? The only thing left by options is diabetic retinopathy. Now students say, अरे मैम कहाँ से आ गई? तनिष्क के बाद पुराना देख रहे हो तुम? नया देखो भाई. Students say diabetic retinopathy, how can there will be painless vision loss? Why not? Diabetic retinopathy is a chronic condition. The only reason of vision loss, sudden vision loss in diabetic patient is vitreous hemorrhage. That is pre-retinal hemorrhage, causing a dark glow, vitreous hemorrhage, floaters, sudden decrease in vision in a diabetic patient is vitreous hemorrhage and can be bilateral. Diabetic retinopathy can be bilateral. So in the options, the best answer is diabetic retinopathy. Diminution of vision was there. Okay, fine. Doesn't matter. Still the answer. Decrease in vision or diminution of vision was there in the question. Zenith, it was not difficult. You can rule out the options. Okay. Anything else to say in this? I don't think so. Let's go on to the 11th one. Now, this is one which, I mean, histopathology or this is the one which I don't tell in the class. Truly. I mentioned some things. I mentioned some things that the discs are present in the outer membranes, outer segments of the disc means what? There are some rods and cones discs which are present. Inner segment of photoreceptors contains the inner segment, outer segment. And the nucleus, that is the outer nuclear layer. In between, there is the outer limiting membrane. So it contains, it is written in mitochondria, Golgi, endoplasmic reticulum. Disc, whatever is the option, disc membranes, maybe the disc, that is the answer over here. The keratoconus is not sudden, Harsh. And sudden can be there in diabetic retinopathy, as I told you. Yeah, D is the answer over here. I think these were the options. I hope I'm telling the options correct. You are correcting me also. I've asked many students. I hope this is correct. Yes, Kavya Somanathan, very good. Now, 12th question, a child with 1400 grams was brought to ophthalmology department by mother, father didn't write. Mother hi lai hogi. Leukocoria, white reflex, and calcification. All of the following can have leukocoria, true. But calcification, what is there? Calcification is seen in what? Retinoblastoma. Retinoblastoma can have leukocoria, congenital cataract, ROP, Coats disease. They don't have calcification. So calcification was the clinching point over here in this question to solve the answer. That is retinoblastoma. Most common presentation of retinoblastoma is leukocoria. Investigation of choice is MRI, but calcification best seen in non-contrast CT scan. Okay? Yeah, correct one. That question is solved. That was the 12th question. Is the option correct? 14-gram birth at 34 weeks. 34 weeks prematurity. Okay, fine. I will add on 34 weeks prematurity. Fine, good. All right. Tauhid Memoon. Tauhid Memoon. Micro is done. You are seeing delayed. Thoda internet ठीक करवाओ or see the live one first. Now, which is seen in the macula cornealoplasty. What is macula now? So nebular macular leukoma 3 corneal opacity involving less than 1/3, 1/3, 2/3, and more than 2/3. Now, anterior segment less than 1/3. If you see through the opacity, of course, they meant through the opacity. Anterior segment is visible, means both iris and pupillar data is visible. That is not the answer. In leukoma, it is more than 2/3. It is not visible. Both iris pupil margin not visible is not the answer. No, details of iris visible, but faintly. That's why the only pupil margin visible should be the best answer in this question. I've got various options in this. I think the best and the suitable options was this. If you can correct me, please let me know. I think it's, if that is okay, I go on to the last question then. Or this was the last. This was the last question. Wow. I thought it is 14, but I think 13. I think if someone is there, please inbox me in my group or TAMS group or in my Telegram group. I think, again, I started with this. Relax now. I hope you have done well. And
Yes,
thanks
yes,
for listening. Dr. Thiru is there. I will hand over to Dr. Thiru. Thank you. Thank you for everyone and best wishes for the results and NEET exam as well. Please, Thiru sir, go ahead.
Okay, very good evening. Yes, my voice clear, sir. Very good evening. My voice slide and clear, sir. Are visible? Okay. Very fantastic evening. I think all are done very good job. I think pharmacology was very, very easy this time. So let us, with the wasting time, we start the discussion. See, PARP inhibitor. That's polyadenosine ribose polymerase inhibitor. Yes, when is the name PARP is there, automatically you know it's the answer is polyadenosine ribose polymerase inhibitor. Okay, any drug name ending with PARP, you know PARP inhibitor. I think all the students have done very good job. The answer also right. Okay, so any drug name ending with the PARP, they call PARP inhibitor. Ribociclib is a CDK4/6. CDK cyclin different kinase 4/6 enzyme blocker useful for treatment of breast cancer. So answer good, Abhishek Roy. I have not got the other option for this question. Anybody? If we have any other option, can you please? Only 2 options I got. So anyway, I will correct the option and post to you. Okay. So PARP inhibitor, polyadenosine ribose polymerase blocker, rucaparib. Okay. Next question. Topical antifungal for onychomycosis. Caspofungin, grisefelvin, tavoborol, fluconazole. The only one topical antifungal FDA approved drug for onychomycosis, tavoborol. Caspofungin useful systemically. Grisefelvin is a systemic drug useful for systemic aspergillosis. Okay, and grisefelvin as useful for topical infection, but given orally. Oral drug, not topical. Oral drug get accumulating in keratin forming layer like skin or the hair follicle or the nail, but given orally. Fluconazole useful for systemic candidiasis, oral drug, IV drug. So topical antifungal mean answer option C. Very good. Now, question number C. Janus kinase inhibitor useful in the treatment of inflammatory bowel disorder. Itraconazole was not there. Itraconazole was there. Okay. my confusion between fluconazole, itraconazole. Okay, but even though itraconazole is there, the answer for the question is travoborole. That's the answer. Oh, it's casovangine, itraconazole. Okay, here is itraconazole. Okay, itraconazole. But anyway, the answer will be travoborole. Okay, casovangine was there. Okay, itra was there. No fluconazole. Okay. Only fluconazole, no fluconazole, only itraconazole. Okay, itraconazole. Anyway, the topical antifungal answers option number C, tavoborole. Okay. Now, Janus kinase inhibitor useful for inflammatory bowel disease. It is tofacitinib. I think it's there. Okay. Ustekinumab, KIN, kin, that means interleukin. It's an interleukin 12 and 23 blocker, not the Janus kinase blocker. Okay. So, answer C. What are the other option? I'm not getting it. So, if we have any other option, please post my Telegram channel as well as our NEETPG official group. Please post it. Okay. So, as I understood, is there? Casmagir is there. Fluconazole is not there. It's a fluconazole. Itraconazole was there. I will correct it. Okay. And then matching type of question somebody posted is vedolizumab is what the yes, vedolizumab. I'll come. IBD, Dabish Banur Khan, vedolizumab. I have the same question. I repeat it one more time. Sorry. We have wait for some time. Matching type question. I think they are given only 3 options, but extra option I have not got from your students. Acetylcholine, nicotinic receptor is a ligand gator. Insulin linked with the tyrosine kinase enzyme linked receptor. Growth hormone cell membrane receptor connected with the Janus kinase enzyme. Thyroid was one. Okay, thyroid was one. Thyroid acting on nuclear receptor. Okay, so this is the answer. So thyroid is one more thing. Okay, so acetylcholine, nicotinic acting on ligand gator. Insulin is a tyrosine kinase enzyme, and growth hormone is a Janus kinase enzyme linked. Thyroid is a nuclear receptor. Okay, this is there. Levothyroxine or thyroid is a nuclear receptor. Okay, right. Calculate the T of, I think about the ask about digoxin. Calculate about T of, no? 46 kg female with the volume of 61 per kg clears 4.6 per liter. Actually, this T of, they ask about T of equal to 0.693 into VD by CL. The only one thing, they given VD 61 per kg, but kg 46. So 46 into 61. This should do. So 0.693 into 61 into 46 by clearance 4.6. It comes around to 42 something. So answer will be option number C. Okay. They use 6 per kg. Okay. Then just so I thought 61. Okay. It is 6. Okay, 6 per kg. Then you see 0.693 into VD. VD equals what? VD 6 per kg. Per kg 6 mean kg 46 into 6. 46 into 6 by 4.6. That's all. Okay. So just 0.693 into 46 into 6 by 4.6. That's all. 4 per hour. 4 per hour, not 4.6. Only 4. Only 4. Okay. Anyway, the formula 0.693 into VD by CL. So I just kg 646, no doubts, no deserve. Well, it was 6 per liter per kg. 6 per, okay, 6, okay. Just go, I will correct and tell you, okay. 6 and clearance 4, only 4. Okay, we'll make it, this formula. Now, please watch this. anti-HIV drug binding to CD4 and also has dual blocking property on CCR5 and CCR4. What answer? What answer? Ibalizumab Maravirac. The right answer, Ibalizumab, a monoclonal antibody targeting against CD4 cell, also has the property of CCR5 and CCR4 blocking. Maravirac purely CCR5 blocker. It has no CCR4 blocking property. So answer A. The option C and option D, I'm not able to get. If we have the option, please post it. I will make a note. Okay. Option C and option D, I'm not able to get. So it's question number 6 regarding anti-retroviral therapy. Coming to question number 7, diastolic BP reduced. Please answer. This is the single response question or multi-response question. Can you please answer? Diastolic BP is reduced by Ibalizumab. Yes, that's answer right. Given right answer. Now tell me, diastolic BP reduced. The given is a single response question or multi-response question. Because alpha-1 blocker causing vasodilatation, thereby they can reduce this both systolic and diastolic, maximal diastolic, multi-response. So this is the right answer. One answer. And beta-1 agonist, beta-1 agonist is going to increase cardiac output. They're going to increase BP. So it is ruled out. It is ruled out. Okay. And vasomotor smooth. Vasomotor is vasodilator causing reduction of peripheral resistance. They also decreasing systolic and diastolic BP. So this also is lumbar sympathetic flow. This also going to decrease BP, but for decreasing BP, usually we follow only A and C. But I know what was not answered. Multi-response question. What are the options? Can you please repeat? One option is fast term severe. One option fast term severe. Fast term severe. Okay. No, it can be single choice. Somebody telling multi-response question. Kalyani telling multi-response question. Javakar telling multi-response question. Dr. MS saying single choice question. Other fellow Kavi telling multiple. So multiple. What is the option? Only 2 options are right or 3 options. What they give? A and C. Okay, A and C is the best answer. Okay, go for A and C. A is the best answer. If multi-response question, go for A and C. Yeah. Yes, good. A and C. D is also there. D is also there. I mean, actually, lumbar sympathetic flow. AC was there, no? AC was there, mean this also it. Because sympathetic also decrease BP. So A, C, D were right answer. Multi-response. Only one thing not going to decrease BP, option B. Others will able to reduce BP. Now, right? A, C, D. Which anesthetic agent causes prolonged adrenal insufficiency? This we discussed in Cushing syndrome chapter. A general anesthetic agent that going to cause adrenal insufficiency, intermediate. This is straight question. Intermediate, a GA able to decreases. Yes, ACD was there. That bunch, yes, that's answer. Good mark. And intermediate able to decreases adrenal hormone, and this also can be useful for Cushing syndrome. So answer is A. Right. Which of following causes slow inactivation of sodium channel? This was confusing. Phenytoin, topiramate, lamotrigine, and lacosamide. Look here. Here, phenytoin, topiramate, lamotrigine. They're all going to prolong the inactivation of sodium channel. A drug slowly inactivating sodium channel, lacosamide. The best answer go for lacosamide. Phenytoin prolonging the inactivated state of sodium ionic channel. Gravir. Okay. One option was something about gravir. One option was gravir. One more option was about indinavir. Okay, I'll make it. Okay. Now, So here the answer is low cost. Very good, very good. Answer D. Yes, good. All right. You are right. So question, phenytoin prolonging the inactive channel, topiramate having multi-mechanism action, sodium blocking property, as well as glutamate antagonism property, lamotrigine sodium blocking property, as well as having just once again. Just once again. So the answer for question option number D, low cost amide. Okay, good. It is the one going to slowly inactivating sodium ionic channel. Okay. Next. I think this one image-based question. Yes. Anti-epileptic drug inhibiting GABA reuptake. Felumate, Sripendal, ganaxolone, tiagabine. Somebody, I think most of the right answer, told right answer, tiagabine. Tiagabine is the one going to inhibit the reuptake of GABA. Felumate, it's an NMDA blocker. Sripendal acting on GABA A receptor. Ganaxolone also modify receptor level. So reuptake blocker mean answer is tiagabine. Answer tiagabine. Are you able to get? Yes. Next question. Yeah. A patient known hypertensive diabetes patient. No, okay. Patient was known diabetic and hypertensive, and his total cholesterol was 240, TGL was 156, and elevated level of HDL. Are you able to see? What is clear? So here also, I think multi-response question. Am I right? See? Yes. No skin. Okay. Okay. What is it? Here, patient was already given statin. His total cholesterol was 240, and TG was 156, and having elevated LDL. What next can be given? Please answer. What's the answer? Here we can use TGL was normal, others elevated. So multi-response question mean I can go for A, B, C. Multi-response question mean go for option number A, B, C. Okay. So TGL is normal. So multi-response question mean go for option A, B, C. Okay. Next, which of following is true about britomanide? Britomanide. Britomanide is never drug for exterior TB. Okay, look here. It acting by reactive species. No, it is acting by inhibiting mycolic acid synthesis. So it is not answer. Useful for exterior TB along with the bedaquiline. Yes, useful for exterior TB along with the bedaquiline and linezolid. It should not be used. No, it has no such drug interaction, so can be given, no doubt. Useful, I think option D, I think mistake. Somebody able to tell right answer me. Can you tell the option? These three options were right. D, somebody told something related to malaria. Exact option was not getting. But anyway, the right answer is option number B. Betamanine useful for exterior TB along with the bedaquiline and linezolid. Okay. Now, liver fluid, drug choice, very simple, very simple. The drug choice, triacylbendazole, a straight or notes, class notes question, straight question, single line question. It's triacylbendazole. Drug not to be useful in uncomplicated malaria. Twist question, question. Drug not useful. Artrimether useful with rufendrin for uncomplicated malaria. We can use. Primaquine not useful for uncomplicated malaria. It is useful only for radical cura vivax. So answer go for option B. Single response question mean resistant malaria. So here they given resistant malaria option D. Okay, I'll make it resistant malaria. Okay, and then the right answer question option number B. Primaquine. Chloroquine can be useful for uncomplicated malaria. Sulfur dioxide can be useful, but not that much useful because the develop resistance. So single response question mean option B. Multi-response mean we can go for option number D also. What is the option? Whether single response question or multi-response question? What answer? What was the question? Drug not useful mean single response mean go for primaquine. Whether a single response question or multi-response question. Can I please get the answer? Proguanil. These options are not there. Only proguanil is there. Okay. So single response go for option primaquine. Yeah, yes. Uncertainty quality patient not responding to any of the TNF of the blocker and progress to severe disease. What is the drug useful as a Janus kind blocker? I think this was the correct question. I will discuss already. It's a tofacitinib. Vedolizumab is alpha 4 beta 7 integrin antagonist. So right answer is I think one option ustekinumab was there. Ustekinumab option D. I will not get it. Anyway, I think all the students are done right job. Tofacitinib is the Janus kinase. Okay, tofacitinib very good. Cytochrome oxidase inhibitor all except hydrosulfide, carbon monoxide, cyanide, except nitric oxide. So cytochrome oxidase mean that you know what is cellular respiration that is attacked by hydrosulfide, carbon monoxide, cyanide. Nitrous oxide not going to inhibit cytochrome oxidase. Okay, so right answer option D. I think matching type of question was there. Naloxone, we know opioid antagonist useful for opioid poisoning. Oxazepam, a benzodiazepine can be useful for delirium tremor. Acamprostate, NMDA blocker having GABA agonism property useful for preventing relapse in alcoholism. Varenicline, a nicotinic agonist useful for controlling smoking cessation. I think matching type of question was there. Okay, so this was the matching. Yes. Comparison of iron isomaltose 1000 and iron dextran. What a comparison. Iron isomaltose cannot be given. No. Iron preparation better can be used to monotherapy or given erythropoietin to improve anemia. So it's a false statement. Immunogenicity more than iron dextran. No, it is less immunogenicity. Safer drug. So false option. Single shot enough. Yes, it can be used a single shot or two shot for controlling anemia. So C is the good answer. Stored adiposite. No, it is stored in reticuloendothelial system. Okay. Benzodiazepine Jack was not mentioned. Okay. Jack was not mentioned here. Okay. Okay. Jack was not mentioned. Okay, my kids. Okay. Okay. And Jack, okay. Benzodiazepine antagonist. Which is correct for? Yes, the correct answer. The correct answer for the question, go for this one. Single shot is enough to catch. Zenith, this is the right answer. Okay. Isomaltase. Correct answer, single shot enough to catch. Which is not effective in preventing COVID-19. Cough etiquette, mask, vaccine. Say all are having a wonderful effective prevention. Ivermectin was no role in preventing COVID-19. It was tested but not proved. So ivermectin has no role, not proved as a preventing for spreading of COVID. Jack was mentioned. Okay, whatever thing you just post. I think these are the questions I collected from our students. If there's small mistake in the question frame or in the option, I just apologize. You post your correct question with the option to my Telegram ID or our DAMS official group, student group. I will correct the question from that. I will make a full PowerPoint presentation for you. So I will switch. Okay. I think this was the almost 19 question I collected for students. So if any question missing, if Dr. Dinesh is there, he can just contribute his idea. What a question he collected. I'm just asking Dr. Dinesh sir to share his view. And if not, students, you please post the correct question option to my Telegram ID and also DAMS group. I will make a full thing and I will present you. Okay. Thank you. May God bless you all the very best. Always. With this, I'm just signing off. Thank you.
Yeah, hello guys. Good evening, all of you, and I hope today's session was wonderful. The exam was moderately, I would say, not very hard, not very easy. It was moderate. So most of the questions has been discussed. I will just ask you if any question was left. So one question was from the general pharmac. I think the sir has been discussed about the half-life calculation. Antidote, if any question not discussed, you can let me know. Antidote correctly matched, I think you know about this question. Correctly matched was the flumazenil. Okay, one question was from the ANS as well, fall in BP, that also sir has discussed. If any question not discussed, you can tell me. This question also discussed by the sir regarding the drug for cholesterol. GET receptor, I think sir has discussed the GET receptor binding. So that is about the tiagabin. So tiagabin is the drug. So all these are anti-epileptic. So you will see a lot of the questions have been asked from the CNS. In CNS, there was the high number of questions and the second was antimicrobial. This question sir has discussed lacosamide. If any question left, you can let me know. In thiopentone, as you know, what is false? So the drug is highly lipid soluble. It is short reaction, not because of elimination. It is short reaction because of the redistribution phenomenon. So it is having the high redistribution. So that also. have been discussed in all the classes and all. General anesthetic related to anesthesia, you know the etomidate is the drug, which is adrenal suppression. Fosphenytoin, one question was regarding the fosphenytoin. So in the fosphenytoin, you can see the question is about the fosphenytoin option, what is true. If you ask me regarding the fosphenytoin, it is the prodrug of phenytoin. It is given parenterally. High dose can cause the cerebellar toxicity. You know that is true, because in the toxicity of phenytoin or fosphenytoin, there are three important toxicity. One is cerebellar toxicity, nystagmus ataxia. One is cerebral toxicity, and one is cardiovascular toxicity. So these three toxicities are there. That is true. In high dose causing nephrotoxicity, that is not true. It can cause the cardiotoxicity, not the nephrotoxicity. It can be given to all seizure patients in emergency respect of the BP. That is not true, because it is causing hypotension. So not to be given for the patients who are having the hypotension. And one option was regarding the safe dose. Pediatric patient, fosphenytoin, whether high chance of arrhythmia or nephrotoxic. So definitely the chance of arrhythmia is there, not the nephrotoxicity, because phenytoin is cardiotoxic, as I told you. Okay, so whether if you ask, if you can provide the exact option, Dr. Nihal, then definitely I can tell you. Cardiotoxicity in elderly and nephrotoxicity in younger age group was given. So it is not nephrotoxic drug, it is the cardiotoxic drug, as I told you. If you ask me the safe dose, it was the safe dose is around 10 to 15 milligram per kilogram, but I don't know the exact option. So if you see, if the question was regarding the true option or false option, then you have to see the options carefully, and then definitely the answer will be correct, because it is causing cerebellar toxicity, it is causing cardiovascular toxicity, it is causing cerebral toxicity, it is causing hypotension, it is causing arrhythmia, and the safe dose is around 10 to 15 milligram per kilogram. The difference between phenytoin and fosphenytoin, it is better option in the IV, because if you give the phenytoin via IV route, then there is risk of necrosis, or there is risk of the purple hand syndrome or purple glove syndrome is possible. So according to options, you can select the correct answer. Correctly matched, I think everybody knows the correctly matched. This was the simple question integrated with the psychiatry. What is correctly matched out of these? Or in the autocoids, one question was regarding the JAK inhibitor. So whenever the JAK inhibitor is there, you have to select the CETINib. So simple question were there from the newer drugs like JAK inhibitor. In antimicrobial, the question was regarding the CD4 inhibitor, and this was the ibalizumab. So I told you Bali, right? So ibalizumab is related to CD4 receptor, and it is the drug inhibiting the entry. It is the only monoclonal antibody approved for this purpose. Then topical antifungal for onychomycosis. Only 2 topical drugs are used in onychomycosis which are FDA approved. So one is terbinafine, that is not in the option. So tavabarol is the drug which is in the option. So I think these questions have been discussed by the sir. If any other question, you can ask me. So in Pharmac, I would say around 20 questions were there, and most of the questions sir has already discussed. The difficulty level was not very high this time in pharmacology. Most of the questions have been discussed in the classes as well, and some questions were integrated questions with the psychiatry or with the other subject. So this is about the pharmacology. Thank you, Dr. Thiru sir, and thanks all the students. So now I will ask the other faculties to take over the stage and continue with the INICET recall. Thank you guys. Good evening. Namaskar.
Very good evening, everyone. Is audio video fine? Can we start with the session? Everyone, is audio video fine? Very good evening, Nihal Bida. Let's start with the ENT segment. As for the MCQs, I will again discuss all these MCQs with all the options in detail. But as if now we are discussing the important points, important topics from where they pick the MCQ. And I request everyone kindly update all the options which were there. Till now, what I have collected, 8 MCQs were there in ENT. So let's start from the first one. They have shown you a slide. The MCQ number 1 from Pathology. Yes, can we start? The MCQ that this slide was shown to you. Every student kindly update in the chat box. Yes, they have shown you something like on step is surgery. After step is surgery, they have given you one processes and they ask you which surgery is being done. I'm sharing the screenshot. Yes, very good evening, everyone. I'm sharing the screenshot of all the pages of my workbook from where these questions were formatted, just to give you a faith, beta. Okay? Have faith on the ultra concise notes and follow them religiously, beta. Now, this slide was shown. Most of the students were saying the same slide was there in the examination, and they ask you something related with the surgery. Now, options were, yes, everyone kindly update in the chat box, stepidotomy, stepidectomy. So as for the discussion with the students, the footplate was shown there. The footplate was there. It means I will be going with stepidotomy. Now the close choice, the other students who have attempted ossiculoplasty, no beta. Ossiculoplasty will be somewhere related with the CSM, ASM. Am I understandable? Clear? In CSM, in tubotympanic ear, in tympanoplasty, when we do OCR, ossicular chain reconstruction, then we'll be going with ossiculoplasty. Now, yes, Abhishek Beda, thanks for update. One of the students is telling a pregnant female was mentioned. It means examiner was giving you a clue for your otosclerosis. If it is otosclerosis, so better choice will be stepidotomy. So what I feel, the answer should be stepidotomy will be the better option because patient was from segment of otosclerosis. Clear? So if you discuss, I'm sharing the page number 105 from my workbook from where we have discussed short sign. I was expecting one MCQ on short sign because it was the last NEET question. They can ask you short sign in INICET, contraindication for surgery. But what they have asked you, they have shown you this image and they have asked you the surgery. Yes, so it will be only prosthesis. Even better, doctors, Nihal beta, even nowadays we are preferring stepidotomy over stepidectomy. So if we are keeping the processes and all those things, so it will be better to go with stepidotomy. I'm understandable. Clear? So the next MCQ they have taken from your hearing loss. This again we have discussed in the class. Even in the TND batch we have discussed this point. What will be, which area will be having maximum hearing loss? MCQ number 2. Which area will be having maximum hearing loss? Option which were very close option were serous otitis media with extra fluid. They have used the word serous otitis media with effusion. Now question is whether ossicular interruption with intact drum is having more hearing loss or serous otitis media. So always remember beta, when there is extra fluid in the middle ear, it can be a medium for transmission. But when there is an ossicular interruption, it will be more loss. I hope you are getting my point beta. If there is a extra fluid in the middle ear, if we compare with the close choice of ossicular interruption with intact drum, both have the hearing loss around 40-50 decibel. But if you want to choose one which is maximum hearing loss, it will be going for ossicular interruption with intact drum. This will be the better choice. Maximum hearing loss will be your ossicular interruption with the intact drum. Perforated tympanic membrane was not there in the option, beta, not at all. Instead of that, the option was serous otitis media. So if the word serous otitis media is there, that we have to compare with the ossicular interruption. Clear? One of the student is asking how to differentiate between stepidotomy and stepidectomy. But nowadays we are keeping the processes and this surgery we prefer stepidotomy. So it is better option. Clear? So ossicular discontinuity, where these are not the option, these are the part of my workbook where I explain how to decide the hearing loss. Complete obstruction of ear canal is around 30 decibel. If there is a perforation, it is around 10 to 40 decibel. If there is ossicular interruption with intact drum, it go around 54 decibel. With perforation, sound directly hit ear promontory and the loss come to 38 decibel. But the examiner confuse you by giving two options. One is ossicular interruption. These were not the option. Just remember, ossicular interruption with intact drum will be having more, or you will be having serous otitis media more. Answer will be ossicular interruption with intact drum will be having more because there will be loss of transmission medium in the middle ear. Kindly thumbs up if you got this concept, beta. Yes, beta. Ishika, we have discussed. Thanks for the update. We have discussed this point in our TND as well as regular batch. All these, beta, I am showing the screenshot of all my workbook pages. Page numbers 27. I always say that trauma is the most important topic. They have asked you Chevrolet fracture. They have shown you something like this. There was a vertical fracture. Yes, Dr. Tanishq, beta. This is option B. The third MCQ was from here. Trauma of the nasal cavity, septum, facial fracture, vertical fracture. Vertical fracture will be option B. Option B. Clear? Is this concept clear? Option B. Clear? All the students joining now. Beta, first MCQ we have discussed with the stepidotomy. The second, maximum hearing loss will be ossicular interruption with your intact drum. 1/3 MCQ with Chevrolet fracture from below. Now, the MCQ, the slide which I have discussed in my DVT last year, most of the students were saying the same slide was there in the examination where they have shown you AC, BC, both beyond air conduction, bone conduction, both beyond 25 decibel, but there was a significant air-bone gap. So what we have learned? AC, BC, both pathway are abnormal. So beta, it means, what does it mean? It means my common destination is gone. It means my cochlea or retrocochlea is gone. I can label it as sensorineural deafness. But examiner have shown you significant air-bone gap, which is more than 15 to 20 decibel. That's why we will be going for mixed deafness. So the better option in this MCQ will be mixed deafness. If you combine our DVT slide with the concept which we have learned in audiometry, the answer will be going in the favor of mixed deafness. MCQ will be here, mixed deafness. Clear? Coming to one of the MCQ, they have, if you remember in the classroom, we have made this table, which is the most dangerous position, bilateral recurrent or bilateral superior laryngeal nerve palsy. You tell me, beta. Bilateral recurrent laryngeal nerve palsy, and I will be discussing with all the options. Day after tomorrow, we'll be having a detailed discussion of ENT MCQs. Here, I am discussing the topic from where they have taken the top MCQ. What concept they have asked you, I'm discussing with you. Concentrate. Which will be more dangerous for the patient? Bilateral recurrent nerve palsy or bilateral superior laryngeal nerve palsy? Everybody kindly help me in making the choices. So most of the students were saying that it was bilateral recurrent laryngeal nerve palsy. What table we have made, dyspnea will be the prime symptom. Both the vocal cord will be in the midline and it will be dangerous position for the patient, dyspnea. Bilateral superior laryngeal nerve palsy, beta, both the vocal cord will be abducted. Patient will be having aphonia with aspiration. Now you tell me which is more dangerous. Bilateral recurrent laryngeal nerve palsy will be more dangerous. Now where is the confusion? Confusion is the student have asked you by partial. The exam, many students were saying in the recall in my Telegram group, students, the examiner have asked you partial. They have used word partial. If partial, even then, beta, bilateral recurrent laryngeal nerve palsy, dyspnea will be the symptom which is more disturbed. Clear? If there was no option for superior laryngeal nerve, option was not there. If it partial unilateral recurrent, partial bilateral, partial bilateral will be, yes, partial bilateral or complete bilateral. If they have mentioned bilateral recurrent laryngeal nerve palsy and you have to choose between partial and complete, it obviously it will be complete. It will be complete. Complete bilateral recurrent laryngeal nerve palsy will be. Okay, I got the options now, beta. It will be the best answer will be Abhishek, beta. You tell me. You always in every discussion, Dr. Abhishek Roy, you respond very fast. You tell me answer will be bilateral, complete, recurrent laryngeal nerve palsy. Why? Because both vocal cord will be in your adducted position, ADD, adducted. All the options were recurrent. Thanks, beta. Thanks for correcting me. All the options were recurrent laryngeal nerve, so it will be bilateral, complete, recurrent laryngeal nerve palsy. Bilateral, complete, palsy. Then coming to the next MCQ, even our team will be discussing with you. They have asked you something on the difference between epiglottitis and Group, which organism is there? Para-influenza virus. We have discussed this on page number 198. They have asked you the organism for group. That page number 101, we always discuss auto-acoustic emission. Which of the following will be the screening procedure in a newborn? Everybody have confirmed they have not mentioned the word high-risk baby. If they have not mentioned the word high-risk baby, so you tell me, beta, you tell me what will be the best option. Auto-acoustic emission. Best option will be auto-acoustic emission. Anyone kindly update the choices? Can you help me in making choices, beta? Yes. Auto-acoustic emission. If they have mentioned the word high-risk baby, then the answer will be going in favor of your beta. Brainstem evoke response audiometry. Everyone kindly update, beta, were they asking the high-risk baby or they have just mentioned the word newborn? It will be auto-acoustic emission. Auto-acoustic emission. It will be, yes. Most common organism of group will be para-influenza virus, beta. We have discussed auto-acoustic emission. One of the students is saying para-influenza virus was not in the option. Beta, group laryngotracheobronchitis is a viral infection. Most of the students were telling the rest three options were they have given some bacteria and they have mentioned only in one option para-influenza virus. That will be the right answer. If just newborn is mentioned, it will be no high risk is there. It will be your auto-acoustic emission. High risk baby, we will be going for para. Brainstem evoke response audiometry. Done. Then from page number 86 of my workbook, they have asked you something related with maximum hearing loss at 2000. All the students, beta, will have complete discussion of these MCQs. I will discuss all the expected MCQs for upcoming next examination. But this is just a recall where I'm confirming the choices. Clear? But if para-influenza virus was not there, so just give me some time. We'll discuss with all the four options. What were the four options? Thanks for updating. Para-influenza virus was not there in the choice. Thanks for the update. Clear? Maximum hearing loss at 2000 Hz, that is Carhart notch. They have asked you two MCQs related with otosclerosis. One, pregnant female. They have asked you which surgery was being done. And one, they have asked you Carhart notch. Clear? So answer will be otosclerosis. Answer will be otosclerosis. Clear? So, beta, any other question? Next 5 minutes, any point you want me to discuss? Any other point which I missed out? So, everyone, beta, best wishes for your upcoming examination. Work hard, and I'm confident, beta. All the students who work, who revise the things in a religious way, you stuck to one source, revise it multiple times, and take my words, beta. You just compare all the questions, compare all the right answers. Take my words, you will realize one point. The ultra concise notes are the game changer. So work hard on the ultra concise notes. Best wishes. Yes, kindly update me if any MCQ left out. We have discussed 8 MCQs. Inferior turbinate. One of the students is asking me about something about inferior turbinate. Can you update, beta? Which version? Which was a inferior turbinate MCQ? One cadaveric image of nasal cavity was shown. Okay. And then what was the MCQ, beta? If inferior turbinate, lateral wall of the nose, they may have asked you something about ET tube, which structure is present at the level of inferior turbinate. So 1.25 centimeter behind, there was ET tube. They may have asked you something about related with the ET tube. Most posterior part, if behind inferior turbinate, they have asked you something inferior. But one of the students is saying nasolacrimal duct opening, they have asked. But I will confirm this MCQ. If it is inferior turbinate, posterior part of inferior meatus, behind that area will be your ET tube opening. Let me discuss this question. If they have asked you the posterior extension, it must be your ET tube, beta. Okay, no worries, beta. I will discuss this point, this MCQ in my ENT complete discussion of the MCQs. Thanks a lot for listening to me. Best wishes, beta. We all are waiting for you people for the interview. Best wishes, and we are confident all our students will be coming with flying colors. Best wishes. I will request the next faculty to kindly share the screen.
Hi, good evening. Is the audio video clear? Yes, so I have collected some questions of today's exam in surgery. Surgery, I would say it was not very tough. It was most of it from the notes only. Okay, so it was not tough. So let's discuss some of the options I have and a few options maybe you will help me in collecting. So there will be a proper surgery recall discussion. This is just for the first day we are looking at this. Okay, now the audio is okay. Yes. Okay, let's see the question. Not an adjunct to the primary survey in trauma. Chest X-ray, pelvis X-ray, yes. Fast, E-fast, yes. CECT, MRI, these things are not used in the primary survey. It takes time, and in primary survey, the patient does not have that much time. So CCT is the answer. I guess these were the correct option. In any case, if you find that my options are not correct, this is totally memory based, so you can correct me. Okay, CCT is the answer. No confusion in that straight away. Okay. Next question. Now you tell me. They have asked about this ergonomics in the laparoscopy. Some angle they had asked. Now you tell me this angle was between camera and the instrument. So if it is between camera and instrument, it is azimuth angle. Manipulation between two instrument. And elevation with the horizontal surface. With the horizontal surface. Yes, whatever CT it is, Rajdeep, maybe CCT or CT, whatever CT takes time. So if the angle was asked between camera and the instrument, then azimuth angle is the correct answer. Azimuth is the correct answer. Okay, so I guess this was the question. Angle between the camera and the instrument in the laparoscopic surgery, that is azimuth angle. Now you can correct me if I'm wrong in getting the question or getting the options wrong. So you can correct me. Okay, this session is about this only. Next question. Investigation of choice for ureteric calculi. I guess Sumer sir also discussed. This is straightforward, non-contrast CT. For renal calculi, ureteric calculi, this is the investigation of choice, non-contrast CT. Okay. Oh, no confusion in this. Now tell me this question. Bed sore patient. I guess there was no image. They just asked about the grading. And in the question, it was written partial thickness skin involvement. So if there is partial thickness, it is grade 2. Grade 1 only erythema and edema. Grade 3 full thickness, but not beyond the fascia. Grade 4 beyond fascia if it involves muscle, bone. So if it was partial thickness, then it should be 2, grade 2. Clean shallow ulcer, yes, fine, but was the muscle visible? Was the bone visible? No, then it should be partial thickness written, clean ulcer, it should be 2. Okay, Mrunal. Okay, most dangerous nerve injury in thyroid surgery. I guess Deepak sir had just discussed. It should be bilateral recurrent laryngeal nerve complete, which will cause airway obstruction because the vocal cords will come in the midline, and it is the most dangerous type of injury. Bilateral recurrent laryngeal nerve complete. Okay, partial will also cause problem, but complete it will be much more dangerous. Okay, so B, bilateral recurrent laryngeal nerve complete. Next, now this is a bit confusing. Tell me, breast cancer, there was a question on staging. 6 by 3 centimeter mass. This is what I got from our discussion with the, you students only on the Telegram group. Pectoralis major involved. So pectoralis major is not considered as a chest wall involvement. So looking at just this thing, it should be T3. Ipsilateral level 1 and 2 lymph node involved, which were fixed. So if it is fixed, then it will be N2A. No distant metastasis, M0. M0. So tell me, was this the exact question or there was some changes you want me to make in the question? Even if the bed sore is for 2 years or 3 years, it doesn't matter. The duration does not matter. The only thing on which the grading depends is the depth. Okay, if the muscle is involved, dimpling of skin also doesn't matter. But if the muscle is involved, then it would be, yes, fixed means matted only. Okay, Marhol, matted only. Matted is fixed. Dimpling is present. Okay, you are saying dimpling. Dimpling also does not fit into the, it does not fit into the, the skin involvement. Okay, skin dimpling is also doesn't matter. So it will be T3 and 2A M0. Okay, you can say this is stage 3A. Locally advanced breast cancer. Nipple discharge also, if there is nipple discharge, that will also does not change our staging. Even if there is nipple discharge, the staging will not change. Okay, so T3 and 2A M0. Even if there is nipple retraction, then also it will not change the staging. Dimpling, puckering, nipple retraction, pectoralis muscle involvement, all in these cases, you will take the size as per the criteria. Okay, the size will be taken. Ulcer tha, light yagmi. If there was ulcer on the skin, then it will be T4. If it was ulcer, then it will be T4B. If ulcer was there. Yes, if ulcer was there, then it would be T4B. So, let's see. I'll try to find some other recalls also, and let's see what was the exact question. If you're saying ulcer, then it will be T4B. And if it is T4, then the stage will become 3B. Yes, so I told you, if it was ulcer, then it is T4, otherwise it is T3. Okay, moving to the next question, multiple rib fractures from 5 to 8. They had asked about the pain management. Okay, so looks like a plain chest patient. They were asking about the pain management. We'll give thoracic epidural analgesia. Thoracic epidural block, not cervical, not lumbar, not supraclavicular. Straight away, thoracic epidural. Thoracic epidural. Okay, if there was no ulcer, it would be T3. Thoracic epidural is the answer. First step in a suspected pheochromocytoma, patient presented with hypertension and headache. So if it is a suspected pheochromocytoma, first of all, you have to make sure whether pheochromocytoma is there or not. So if it is suspected, first you make sure by this 24-hour urinary metanephrine. If these are high, then the next step should be to localize, and in this localization, you'll go for the CT scan next. If CT fails to localize, then you go for MRI. This we had discussed multiple times in the class, in the TNDs, even in the INICET, the series, we had discussed this. Yes, 3 to 8, 5 to 8 doesn't matter. You're saying 3 to 8, let's take it 3 to 8. The answer doesn't change. Okay, 24-hour urinary metanephrine straight away, not difficult. Till now, no difficult question as such. Now, here the options, you just correct me. Head trauma patient, GCS was low, systolic blood pressure was also low, absent breath sounds on the right side. Next step in the management. Next step in the management. Okay, there was a question on tertiary intention healing. Let me write tertiary intention. That also we had discussed. primary, secondary, and tertiary intention healing seen in the delayed primary suturing or in the skin grafting. Okay, so see, head trauma patient, GCS is poor, systolic blood pressure. Next step in the management. Okay, looking at this, this looks like a tension pneumothorax. Not this option. Order of management asks, okay, order of management. So no matter what is the injury, order we follow is this only. Airway, breathing, circulation. Sequence was given, no? Sequence. So the first thing is airway. Airway means because the GCS is poor, you intubate. Then you put a needle. Needle thoracocentesis, ICD, and then you put the IV. Then you give the IV fluid. Absent breath sounds was not mentioned. Okay, chalo. This was not mentioned. So let's say it was not there. Chest tube drainage was there. Yes, correct. This is the correct order. Whoever has marked this. Airway, then needle, IV fluid. This is the order. Okay, so let's say A, C, B. A, C, B. One option was first look for head injury. That is absolutely not correct. Dr. Swat. Starting with chest X-ray, absolutely not there. Zenith is saying breath sounds were given absent. That is okay. It was mentioned. Fine, fine. So this is the order. Okay. No matter what is the injury in trauma, we have to follow the sequence: airway, breathing, circulation, disability, exposure, and environmental control. Yes, if there was no needle, then ICD is fine. If there was no needle, ICD was written, then ICD should be there. Okay, so no confusion in this. This was also not tough. It was straight away trauma question. Now see this question. Papillary thyroid cancer in one lobe, no lymph node, history of radiation in the past for Hodgkin's lymphoma. Suppose a radiation option was not there. Papillary thyroid cancer is a good cancer, only on one side, less than 4 centimeter. We can very well go for a hemithyroidectomy. But history of radiation in the past, now hemithyroidectomy will not be done. We'll go for total thyroidectomy. Tell me if there was any other options apart from this. Definitely there will be options. Just tell me so we can discuss more. But if history of radiation in the past was not mentioned, then hemithyroidectomy would have been the answer. Needle was not there, no problem. ICD should be the thing. Okay. Total thyroidectomy because there is radiation, history of radiation. This we had discussed in the class, then when to go for hemi, when to go for total thyroidectomy in case of papillary thyroid cancer. Yes, radiation history present, so that's why total thyroidectomy. Total thyroidectomy. Modified radical neck dissection is not required because there is no lymph node involvement. So if there is no lymph node involvement, modified radical neck dissection is not required. Okay, so if there was no other option, there was only total thyroidectomy with MRND, then you can go for it. But otherwise, if there was an option of total thyroidectomy and another option of total thyroidectomy with MRND, then total thyroidectomy would be the answer. No hemithyroidectomy, total should be there. And if there was something about the lymph node, I mean in all the options, there was thyroid with something to the lymph node, then yes, modified radical neck dissection should be done. 2 by 3 centimeter is fine, 2 by 3 centimeter. If radiation wala point was not there, then we can go for hemithyroidectomy, but now we have to go for a total. Okay, so you can say right total with lymph node dissection if there was, all the options had lymph node dissection. Yes, total with lymph node dissection should be the answer. Okay. Now this question, splenectomy was done close to the stomach. Spleen is present very close to the stomach anyways. Bleeding occurs in the post-op period. What is the source of bleeding? Okay, what is the source of bleeding? One question on echinococcus. Echinococcus, I mean micro wala part echinococcus or the surgery wala part hydrated. If the question was on hydrated, then we can see. If the question was on echinococcus, maybe the microbiology sir will discuss. Bleeding from the short gastric vessel. Okay, because this part is very close. This is the stomach and the spleen is present like this. And these are the short gastric vessels. So at times after the surgery, the bleeding from the short gastric vessel can occur. Okay, so total with neck dissection should be the answer. Here in this question, short gastric vessel should be the answer. Left gastric artery is present here. Okay, so left gastric is absolutely not related to the splenectomy. Okay, left gastric is present here. This is the left gastric artery. It is far away from the spleen. Yeah, also, the supply from the left gastric does not go to the spleen. So left gastric is not the option. Short gastric is the answer. Tumor marker. Tell me, this was the match the following question or something else? Match the following question. Bleeding via dissection, bleeding in the post-op period, both the answer will be short gastric. Calcitonin, medullary thyroid cancer, beta HCG, choriocarcinoma, alpha fetoprotein. I guess there was hepatoblastoma in the option. Uretary calculus question we had discussed, Dr. MR, we had discussed NCCT. Okay, we had already discussed. So this is the correct, yes, match the following. This is the correct match. Any other option in this question? I mean, there should be one more thing, no, match the following. So, okay, if these were the option, then this is the answer. Vitamin deficiency in a patient of gastrectomy, straightforward vitamin B12. I guess there was something more given in the question regarding some neurological involvement and all. But yes, vitamin B12 definitely there is deficiency of this. Okay, pheochromocytoma, what was given in the pheo? Catecholamine. Okay, pheocatecholamine. Fine, good. Okay, ileal perforation and the skin was not closed. 5th day closure was done. Okay, 5th day closure was done. So that means it is a tertiary intention because it is a delayed suturing, delayed primary suturing. Okay, this question I guess Sumer sir had discussed. Dysphagia, cough, halitosis, barium swallow was given. A classical Zenkus diverticulum barium was given in the question. Okay, folic acid. Let's see. Okay, folic acid. No problem. Answer is still vitamin B12. Zenkus diverticulum straightforward. No confusion. Gastrinoma boundaries, junction between the cystic duct and the CBD. Second and third part of the duodenum. And junction between neck and body of the pancreas. Okay, we had discussed in the class, in the notes. Barium swallow was given, yes. Romberg sign positive means again neurological involvement. So that is okay. Romberg sign you are saying. So let me see Romberg sign. Okay, so these are the boundaries for gastrinoma triangle. Junction between cystic duct and CBD, second and third part of the duodenum, and neck and body of the pancreas. Passaro triangle, yes, is the another name. CBD and cystic duct, suppose these were the separate options, then cystic duct would be the better answer, where the cystic duct drains into the CBD. Okay, because CBD, the whole CBD is quite long. Okay, so that cannot make a triangle. So among, suppose these two are separate, then cystic duct would be a better, the landmark. Okay, so cystic duct is better. Cystic duct is better. CBD is almost 7 to 10 centimeter long. Cystic duct is the better answer in that case. Carcinoma esophagus, I guess the question was when dysphagia occurs, how it occurs initially more to solids or more to the liquids. So answer is more to the solids, more to liquids, initial to the liquids in case of achalasia. In achalasia, initially it is to the liquid. What is the best? I said cystic duct. Cystic duct should be the better answer. Okay, more to the solids. Later it will be complete dysphagia to liquids as well, but initially to the solid and then to the liquid. Oral cancer image. Now the exact image nobody is able to tell or show. So if you have some idea that what was the area, whether it was tongue or the buccal mucosa or it was lip, and whether there was any bony involvement like maxilla, mandible, was there a skin involvement or anything else was option in the anything else was mentioned in the question about some blood vessel involvement or anything else. Then we can come to some thing. Oral cavity cancer, I told you in the classes also that it is an important staging, and they have asked whether depth of invasion was given. Okay, so tell me what was given in the image. What was seen? What was the primary area? Okay, if it was floor of mouth, you are saying alveoli, you are saying, then it would be T4A. 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 Floor of mouth, it will be T4A. Okay. So if you are saying floor of mouth, it will be T4A. Now this question was there or not? First you tell me indication for surgery in parathyroid adenoma. Whether this question was there or not. Teeth involved means alveolus, so that will be again T4A. Okay, if this question was there or not, if it was there, age less than 50 year, serum calcium more than 12, decrease GFR, decrease bone mineral density, and more than 24-hour urine is having more than 400 milligram calcium. It was there. So yes, tell me what was there. These are the asymptomatic patient, or there should be symptoms. Investigation of choice for surgery of PTH. I mean, investigation of choice for localization should be CESTA maybe. Okay. Investigation for the completeness of the surgery, then it would be either a frozen section or it would be Miami criteria. Yes, so if the calcium was 12.8, if you're saying calcium was given 12.8, then it is an indication. Then it was investigation to decide surgery. This thing, DEXA scan, calcium, renal function test, all these investigations are done to decide whether to go for surgery or not. Okay, so this was the question. So if I'll come to know the exact question and the option, we'll discuss this in our, the proper discussion of the surgery. Acute pancreatitis, I guess the question was, which is more specific, whether amylase or lipase, which is more specific. This is a very easy question. Lipase obviously is more specific than amylase. Amylase can be raised in other conditions also, like appendicitis, PID, perforation also. Yes, if bone scan was there, DEXA, bone scan. No, bone scan is not. DEXA should be. Yes, DEXA was given, then DEXA should be the answer. If DEXA was given, then it should be the answer. DEXA, then it should be the answer. Okay, Tulsi. Amylase lipase, or there was anything else in these option, more specific amylase lipase or something else was also there. Yes, lipase. Okay. true love and which classification is done for ulcerative colitis. Okay, based on this, there can be mild, moderate, severe, and fulminant type of ulcerative colitis, depending on the frequency of the stools and whether there are systemic symptoms present or not, tachycardia, toxic megacolon, all these things. Based on that, this classification on ulcerative colitis was there. Okay, so that is this question. Was there a question on ERAS protocol also? And what was the question? There was something on ERAS protocol. Just statement type option in the pancreatitis. If you remember any statement, let me know. Otherwise, if any of the statement was saying that lipase is more specific than amylase, then that statement would be correct. Enhanced recovery after surgery. Okay, there is so many things we do in this in the pre-op period, in the post-op period. Okay, ERAS protocol. Anything on this? The pre-op, intra-op, and in the post-op period, multiple things is done for the early recovery of the patient. For the early recovery of the patient, okay, pre-op optimization of the patient, prolonged fasting should not be there. Yes, prolonged fasting is not recommended, is correct. Prolonged fasting is not recommended is the correct option. Frax is not, that is not surgery question. I don't think that is surgery question. Okay. So prolonged fasting not recommended should be the ERAS protocol. Yes. Was there a question on blast injury? Any question on the blast injury? Something given that some kind of explosion or the bomb blast has occurred and there is some penetrating injury. If there is penetrating injury, then it is secondary. If there is a blunt injury, then it is tertiary. If because of the pressure, then it is primary. Burn is quaternary. Fracture risk assessment, that's why I'm saying this is not surgery question. Fracture is not surgery. Yes, even Marshall's type of blast injury with penetrating injuries, yes, secondary. Secondary blast injury. Puncture, secondary. Okay. Then, like you said, there was a question on the skin was left open after laparotomy and closure on 5th day. This is delayed primary suturing. And delayed primary suturing comes in tertiary intention. If you keep it open, if you don't close it, then it will be secondary intention. And if you close it at that time only, it will be primary intention. Abrasion, laceration, and if there is a puncture wound, it will be penetrating only. Then it will be secondary. If there was no puncture, no penetration, then it would be tertiary. Okay, so it would be tertiary. Okay, so these were the questions of the surgery. If I come to know any more question, or if you tell me any more question, we can discuss that also in the proper discussion. Okay, yes, closed after 5 days, it will be tertiary intention. Okay, so these were the questions which I could collect. Now, I would request the next faculty to join for the discussion. Okay, tertiary intention should be the answer. Thank you. Thank you very much. We'll come with the proper discussion of when we get the other questions and the other options.
Hello, everyone. So can you hear me? Am I audible? So once I hear that I'm audible and you can hear me, we'll start. All of you, am I audible? Visible?
Yes, sir, you're audible and visible, sir.
Thank you. So what I'll do is I will be discussing on behalf of all the pediatrics faculties of DAMS, the INICET questions of pediatrics. So before we go to the questions, let me analyze it for you guys. And there's no doubt that all the previous year topics are important. So it's not about PYQs, it's about PYTs. So guys, you need to have a common source and keep on revising that. Today, I'll show you that all the questions were definitely from all our notes. They were from back to basics. And I'll show you screenshots of all of our lectures. So there were almost 10 to 12 questions. And I'll show you each and every question from our notes. Now, the first question was on cystic fibrosis. And the question was, what is not seen in cystic fibrosis? So can anyone tell me what were the options? Because I think there was a doubt of duodenal atresia. Was it there, or were these all of these the options? What is not seen in cystic fibrosis? Meconium ileus is of course seen in the infancy in cystic fibrosis. So all of you in the chat box, if you have any other option in your mind which came in your exam, please let me know. Now, diarrhea can also be seen in cystic fibrosis. So there's no doubt they can have diarrhea. Now, yes, diarrhea can be seen sometimes. So Dr. Nihal in the chat box, it can be seen. Coagulopathy, of course, it's because of the malabsorption and the liver disease, they can have coagulopathy. Nasal polyps are important. So every class of mine, and if you go to back to basics, guys, there is a 20-minute lecture on cystic fibrosis where I tell you guys that the whole life cycle is important. And if you go to the last year INICET, in the last year INICET, there was a question on hyponatremia. So all their life and in each of every class of mine, I tell you that hyponatremia all their life. Now look at infancy, meconium ileus, rectal prolapse, nasal polyps. So you need to know the whole life cycle of cystic fibrosis. So now some of the students are saying that there was an option of biliary atresia. So of course, whether it's biliary or duodenal atresia, they are not seen in cystic fibrosis. Okay, what is not seen in children? Of course, they are not seen in children. Okay, so I will improve it. What is not seen in children? So of course, these anomalies, this all holds true for children. So duodenal atresia or biliary atresia is not seen. Let's take you to the next question. And in every INICET, guys, there is a match the following on genetics. Now, I know of the first three options. We all know spinal muscular atrophy is autosomal recessive. Duchenne's is X-linked recessive. Leber's hereditary optic neuropathy, LHON, is mitochondrial. Guys, can anyone tell me what was the option in trinucleotide repeats? Yes, Dr. Meghna, meconium ileus infants में तो देखा जाता है. Of course, meconium ileus. Meghna, यहाँ पीछे देखो, ये देखो, left side पे देखो. Meconium ileus is seen in infancy. Okay, so can anyone tell me what was the option of trinucleotide repeats in this match the following? Okay, spinobulbar atrophy. Lovely, Dr. Akila. You're right. Spinobulbar atrophy. So I have correctly matched all of these options. Now I can tell you in every class of yours, we have a special lecture on genetics. We talk of Mendelian and non-Mendelian genetics. So if you go to back to basics, I always talk about Duchenne's. And in fact, guys, whether it's NEET PG or INICET, genetics is important. So in fact, in 22 NEET PG, there was a question on Duchenne's. So there is no doubt Duchenne's is X-linked recessive. Now, I always tell कि आजकल का in thing है SMA because of the gene therapy available. There is a single one-time injection which is called onasemnogene abeparovec, which is available for 16 crores and it has been given in India. So SMA is the in thing these days. So last year INICET में आया था, SMA has lower motor neuron weakness. Fasciculations are seen in SMA. Okay, so if SMA was not there, then some of the students are saying cystic fibrosis was the option. So cystic fibrosis is also autosomal recessive. So this is the correct way, guys. Duchenne's X-linked recessive, Leber's mitochondrial, spinobulbar atrophy, trinucleotide repeat disorders. Okay, cool. Okay. SMA is autosomal recessive. Zenith. So now, can all of you share with me that there were 2 questions on severe acute malnutrition? There were 2 questions on severe acute malnutrition. Am I right? There were 2 questions. Now, first question was on definition of SAM. Okay. First question was on definition. Now, in each class, guys, we always talk about SAM. Now, all of you should know that SAM definition has weight for height. When we talk about acute malnutrition, weight for height below -3 standard deviation, number 1. Number 2, bilateral edema, mid-arm circumference below 11.5 centimeters. So, her class mein, every GT of yours, every CBT of yours, you will have a question on SAM. So, as you can see here, weight for height less than -3 standard deviation, edema. Now, some students are saying that mid upper arm circumference mein 11.5 centimeters was not mentioned. It's okay. So, acute malnutrition, height is not a marker for acute malnutrition. Some students are saying, sir, weight for age likha tha. So, of course, weight for age is also not a part of severe acute malnutrition. Okay, cool. Now, there was a question on criteria for discharge. Now, I want all of you to tell me what were the options of criteria for discharge. See, in every class of mine, I always talk about this. That beta, याद रखना है criteria for discharge में 2 important है. Edema. Question was not to assess. Yeah, so of course, height is not to assess. Height does not help, Sakshi, for SAM. It is weight for height, mid-upper arm circumference, edema. Yes, so now there are parameters of recovery. So very good, Shirish. So, or criteria for discharge, or you can say what are the parameters for recovery in SAM. And I'm sure that options would have been edema absent for 2 weeks is a marker. Okay. Okay. Weight for height reaching -2 standard deviation. Weight for height was an option. Good. Edema was there. Edema should be absent for 14 days. Okay. Then, as you can see, weight, consecutive weight gain for 5 gram per kg per day. This is also, of course, yes, very good. Failure to gain 5 gram per kg per day for 2 weeks. So these were the options. Now there is a lot of controversy here, what you are saying here, but I will just tell you what were the options as per your consensus. Failure to lose edema by day 10, someone is saying day 4. So this is of course wrong. Failure to gain weight. 5 gram per kg per day. Now, weight for height was an option. I'm sure there must be a option of weight for height. Should be at least, like I always tell, it should at least reach -2 standard deviation. So all of you, we need more consensus on multiple option of this question. But of course, weight for height to hai. Failure to lose edema by day 4 is wrong. It should be by day 14. So if they have written day 14, this would have been right. Okay. So if they are asking what is true, then weight for height should reach at least -2 standard deviation. So now Snata and Neetu are writing something. Failure to lose edema from day 4. Presence of edema on day 7. So we need more consensus on these options. There are a lot of people adding more options. Failure of edema from day 4. Edema on day 10. Someone is saying edema on day 10. This is also not a good thing. It should go by day 14. Failure to gain weight by day 20 is also not good. Appetite not increased. So there was an option of appetite also. And now one student is saying that weight for height was also an option. So weight for height was definitely correct. Rest, we need to check and then answer. Okay. So multiple correct options. This question was multiple options correct. So all of you, you need to look at the SAM lectures definitely. And remember that these are the common criteria for discharge in SAM. Okay, someone is saying weight for height was not there. Okay, which is incorrect statement. Now we come to this. What is incorrect? So of course, if you look at incorrect, then leaving D, all the other options are incorrect. If you say it's incorrect, and then of course, all of these options are not correct. This is not correct. This is not correct. It should happen earlier. Okay. So in fact, in this INICET, as all of you have told me, most of the questions were what is incorrect instead of what is correct. So this would be, these are the options which are not correct. Now there was a question on breast milk jaundice. And in every class of yours, we talk about the difference between breast milk and breastfeeding jaundice. So this is just a screenshot from Back to Basics. And we always talk about, of course, it's unconjugated. It resolves over 4 to 6 weeks. Remember, at All India Institute, if you look at the AIMS protocols, there is a statement in the AIMS protocols book that in the last 25 years of AIMS NICU, we have never stopped breast milk. I will again repeat, in the last 25 years of AIMS NICU, we have never stopped breast milk in any baby. So correct options are, it's unconjugated. Breast milk has to be continued. Phototherapy is rarely needed, not in all. So all of you, do you agree with me regarding these options? Now, after 3 to 4 weeks, the bilirubin is usually around 5 or so. It is not 10, it is around 5 milligram or so. Okay, so this second option is also wrong because remember, around 4 weeks of breastfeeding, breast milk jaundice, which is a late onset jaundice, which peaks on day 14 of life, bilirubin is around 5 or so. All of you, do you agree with me regarding these options? Let's wait. Phototherapy in few cases. Okay. Then it is correct. Only in few cases. okay, then it is correct. Only in few they may need phototherapy, but not in all. Single option correct? Okay, single option correct. Then total bilirubin is not more than 10. This is wrong. Okay, now Sairam is saying phototherapy in all was given. So phototherapy is given in all. Then this is wrong, beta. This is definitely wrong. This is definitely wrong. There is no doubt. This is so definitely wrong. Okay. So D is definitely wrong. B is partially wrong because usually bilirubin is around 5 to 10. Okay. Okay. Cool. So if it was a single option, of course. Breast milk jaundice is a mild jaundice. It's benign. Yes, it is not. Now, Dr. MS is also saying लिखा था phototherapy is given in most. ये तो definitely गलत है. इसमें कोई doubt ही नहीं. Okay. So D is wrong for sure. If it was a multiple option, then mark B and D. Now, I tell you every day in my classes and all the GTs, I can tell you in the coming CBT, in the coming GTs also, I will talk about neonatal cholestasis. So we talked about neonatal cholestasis in our back to basics. And I've been telling you guys that biliary atresia has to be ruled out. Now, there are controversies that when should Kasais be done? And I'm sure our surgeons also talk about that surgery should be done within the first 2 to 3 months. So guys, can you tell me, do you agree with all of these options? Tell me what were the options in biliary atresia. And then we'll talk about the answer. What were the options in biliary atresia? It's a neonatal cholestasis is a very important topic when we talk about biliary atresia. Guys, last NEET PG में question आया था, liver biopsy of biliary atresia shows ductal proliferation. This was the question in last year's NEET PG. In fact, this year's NEET PG. Correct option. Sairam is saying all the options are correct. Exact options. Abhishek is saying I have correctly recalled all the options. So see, HIDA is not a very good investigation. HIDA is a waste of time most of the times. I can tell you, my colleague in my hospital, she's a very famous pediatric hepatologist who wrote the guidelines for neonatal cholestasis in our country. And the test for biliary atresia is liver biopsy. Okay. So Kasai should be done as soon as possible within 2 to 3 months. And see, look here. Now there are on the left hepatocellular causes, on the right surgical causes. So as a group, hepatocellular may be common, but as a single cause, biliary atresia is the most common cause. In the developed world, definitely biliary atresia is the most common cause. Now, all of you, I'll read a statement from O.P. Ghai for you. Liver biopsy helps in differentiating biliary atresia from other causes of neonatal cholestasis. So HIDA is not a good investigation. Liver biopsy is the best. Okay. Now, there was a question on neonatal resuscitation. And guys, I'm happy to share with you that in the back to basics, we have included a whole small section. We have not added, hours and weeks of videos. It's just a 30-minute video on pulse. And I always talk about when to do chest compressions if you are lay rescuer or you are two rescuers. Of course, one rescuer, 30:2, two rescuers, 15:2. Okay. So do you agree with these options? Sainam, you need to look at whether the question was a single option or multiple options. Okay. If it's a single option, then the answer was definitely HIDA is not done in all. Now, do you agree with these options? What is incorrect statement? Okay, single only. Okay. Okay, this was adenosine and not adrenaline. There are controversies on this actually. Correct statement. Oh, correct. Someone is saying correct. Whatever. Let's talk about that. See, when you talk about CPR, and I discuss in my class also in the back to basics, that of course, if you are alone, 30:2. If you are two rescuers, it's 15:2. Now the depth is 1/3 of the AP diameter of the chest. So see, two rescuers is 15:2. Dose of epinephrine is wrong here. It is wrongly given here. Preferred route is IV. At least, of course, the depth is 1/3 of the AP diameter of the chest. This is true. You're right, completely right, Sairam. You're right that depth 1/3 of the AP diameter of the chest is correct. Rest all is incorrect. Okay. Cool. So 1/3 of the AP diameter depth is correct. Rest all is incorrect. Yes. So if they ask correct, then 1/3. And there was an option of a dose of adenosine, which is of course wrongly given here. Okay, now this is a repeat question. In fact, since last 1 year, every INICET is asking about the NADA's criteria. And I know I'm right, all of these options were given. Now, the first lecture on congenital heart disease in Back to Basics is on NADA's criteria. Okay, where we talk about that you need one major or two minor criteria to call it as a heart disease. One major or two minor. So as you can see here, CHF is a major criteria. Abnormal X-ray, abnormal ECG is a minor criteria. Diastolic murmur, if you look here, is a major criteria. Troponin is, of course, not part of the NADA's. So there is no doubt about this. Troponin is not part of the NADA's criteria. Now, there was a question on milestone, and I know these were the exact options. When can a child copy a cross, tell a story, can go to toilet by himself? And guys, whenever I take a class, and it is there in Back to Basics also, I always tell you कि देखो ये टेबल तो याद रखना ही रखना है. I always tell you 3-year, 4-year, 5-year, this table from Nelson's textbook is very important. और देखो same table से question. Goes to toilet alone. Okay, goes to toilet alone. Tell a story. Copies across is at 4 years. So ये table तो याद रखना ही है. And I always say, print this table, put it on your desk. This always comes. Yes, this is correct recall. Answer was 4 years. Now, in every class, guys, whenever I talk about acute kidney injury, I tell you कि passion हमारा pediatricians जो North India में pediatricians है, हमारा passion है hemolytic uremic syndrome. Every exam of yours will have a question on hemolytic uremic syndrome. And I clearly say, all over the world, the most common cause is E. coli, the Shiga toxin producing E. coli 0157H7. In Bangladesh, it's Shigella, but in the developed countries, you know, I always tell a story in my class कि किसी ने अमेरिका में बर्गर खा लिया, tacos खा लिए, and he got a kidney failure. So, of course, the most common hemolytic uremic syndrome is caused by E. coli 0157H7. And I know my recall is right. Anyone? Sairam, Abhishek, Rishikesh, Nihal? You agree with me? This was told to you in all of your classes? Okay, this is right. Now, was there a question on crew? And can you tell me what were the options of crew? Was there a question on crew and the most common organism? Anyone? See, in all of your classes and now in the handwritten notes also, I told you that, see, whenever we talk about crew or laryngotracheobronchitis, it's mostly viral. And the most common viruses are parainfluenza, followed by the respiratory viruses. So now students are saying parainfluenza was there. Someone is saying influenza was there. See, now listen to me carefully. If parainfluenza is not there, you should know that after this, the respiratory viruses are there. And then influenza can also be an option. But remember, it will be the third common cause, not the most common cause. Okay. So, of course, crew is viral. Okay, Dr. Garima and Abhishek. So crew is viral. So if you have a viral option here, then you mark viral. So most of you are saying parainfluenza was not there. So we will not mark parainfluenza here. Okay, someone was saying there was a strep pneumonia as an option. Okay, so that will definitely not be an answer. So the answer will be influenza. So remember, there's no doubt crew is viral. Okay, so this will be the answer of this question. However, remember, influenza is not a very common cause. Okay, so it's parainfluenza followed by the other respiratory viruses and then influenza virus. Strep pyogenes, okay, whether it's pneumonia or pyogenes beta, they cause epiglottitis. Streptococcus causes epiglottitis. Cool. Viral will be the answer. So that was all about the INICET, and I could gather around 11 questions. So if you have any doubts, guys, feel free to tag me on Instagram or email me. I will be happy to answer all of your questions. Any other question you have in mind? Someone is saying parainfluenza with her. Remember the basic. Okay, don't go after this question, but you should know the basic, that the most common is parainfluenza. Okay, now, of course, Akila is saying there was a question on rotavirus. Most common cause of diarrhea in toddlers is rotavirus. Thank you, Akila. Most common cause of diarrhea in toddlers, rotavirus. There was a question on phototherapy. Okay, can you share with me what was the question on phototherapy? Because I am not aware about that. So one was the most common cause of diarrhea in children more than 2 years. Most common cause diarrhea in children more than 2 years, of course, rotavirus. Now, I don't know if there was a question on, no one told me about phototherapy. Okay. So if you have, if you recollect that, Dr. Ekadashi, let me know about the phototherapy question, because students did not tell us about that. They only told us about the breast milk jaundice question. Okay, maybe you are confusing that with the breast milk jaundice question. Okay. Okay, so I will log off here and I wish you all the best. And guys, remember, it is not just about this INICET. These topics are important for the NEET PG as well. So do remember, do recall these questions. Look at all of these topics. They are very important, even for your NEET PG. Thank you. And remember, revise the notes. Don't, keep on changing your sources. Your notes are good enough. Just remember the notes. And I can tell you guys, हर class में बोलता हूँ कि you are so fortunate that you guys have back to basics as a backup. So use back to basics as your backup. Look at those lectures. They are wonderful, short, crisp lectures. They are not like, weeks of lectures there. So you will be able to cover most of it. Thank you and all the best. And I always say whenever I finish my classes, see you on the other side when you will be a PG and I will be a consultant scolding you guys. All the best. Over to you, Dr. Bharat.
Yes, sir. Thank you, sir. Hello, good evening, students. I hope everybody must be really tired after going through an exhaustive paper. So don't worry, because we are all are with you. I think you will come out with flying colors. Now, coming to the respiratory medicine part. So unfortunately, the recalls were very less. I think most of the students were unable to give the exact recall. One question was this. I hope this must be already discussed. There was a diabetic patient with breathing difficulty and pleural effusion. His CT scan showed tree bud appearance. Pleural fluid showed lymphocytes. Was it low ADA or high ADA, anybody? Because based on this, your diagnosis will change. Aspirate from hilar lymph node shows which of the following. So whenever there is a tree bud pattern, most important is tuberculosis, but rarely even fungal infections may be responsible. And if it was high ADA in a country like India, we go with tuberculosis. Whereas there is lymphocytic effusion with low ADA, and this generally excludes tuberculosis whenever in high incidence countries. So most probably, if it was low ADA, calling it tuberculosis is a bit difficult. So the better answer will be fungal hyphae surrounded by lymphocytes. So was there any other thing given in the question? So it was anything given? If it is low ADA generally excludes tuberculosis. And 30-year-old female, okay. And any other risk factor given? So somebody says it is 30-year-old female. So then if it is younger female, in young females, even if it is only lymphocytic, you can think when there is no other risk factors for fungal infection, then you can think it as tuberculosis, because in this is an elderly diabetic. So I'm thinking in terms of fungal. If it was young patient, lymphocytic effusion, you can think of tuberculosis. Was any history given? Low-grade fever, weight loss, any constitutional symptoms given? Okay, not given. So if it is young, any pleural effusion, lymphocytic in India, you have to first rule out tuberculosis. If it is elderly, then if it is lymphocytic, if ADA is less, you should think beyond TB. Is it malignant? Is it fungal infection? Okay, if it is young, don't worry. If it is young, don't worry. You can, because young patient presenting with fungal is highly unlikely. They are only when they are severely immunocompromised or malnourished. Then somebody has mentioned that there was a chest X-ray cough given with diffuse infiltrates. So bilateral diffuse infiltrates, diabetic, and was the Aquila alati, what was the history given? So diabetic, 60-year-old male, diffuse infiltrates, and it all depends upon the onset. Was it acute or chronic? Was it acute or chronic? Now somebody has changed it to 30-year-old diabetic. Okay. So this is it acute or chronic history? If it is acute, you should think of ARDS, any pneumonia, bacterial pneumonia. Chronic, generally think of tuberculosis. So any other recall questions, please? So anything, any other history or any other questions? So here incorrect statement was asked. Okay, incorrect statement. What was it related to? No history, only chest X-ray was given. Acute shortness of breath, fever, purulent sputum. So then you can think in terms of pneumonia. If it is a shortness of breath with the sputum, so it should be some infection, pneumonia. And if there was some predisposing factor, such as pancreatitis, such as sepsis, then you can think it as ARDS. Okay. Any other recall, students? Any other question on ABG? So was there any question on ABG? Yes. Which is not high anion gap metabolic acidosis. And I think it is very simple. So to call it as high anion gap, it is addition of acid. Something should have added acid to your body. So whatever adds acid, it is high anion gap. This we generally discuss in our classes. Mycoplasma generally presents with interstitial pattern. Very rarely it goes into diffuse pattern. And aspiration pneumonia common. Okay, this was also asked. Aspiration pneumonia. And this I think we generally discuss in our classes. Aspiration pneumonia. Yes. Right lower lobe, superior segment, or right upper lobe, posterior segment. Diarrhea is not high anion gap. Okay. So this is usual. Diarrhea is generally normal anion gap metabolic acidosis. Then anything apart from this, anything regarding COVID, anything regarding spirometry? Somebody has given me regarding COVID, a question was asked. Okay, thank you, Dr. Nazia. Not high anion gap. This is a commonly asked question. We know diarrhea. Yes, it was also discussed in, I suppose, in DBT. Thank you, Dr. Ekadashi. Anything else? Okay. So what was given in COVID? So COVID, what will not protect? Yeah, I think this would be discussed in your physiology regarding the anatomical dead space measurement, the Fowler's method, then physiological dead space. Yeah, peripheral chemoreceptor stimulated by hypoxemia. Okay, those are physiology questions, don't worry. Not useful in COVID. So definitely social distancing, mask, vaccine, hand sanitization, all are helpful in COVID. Ivermectin, not useful. Okay, not useful in COVID. Not useful in COVID. Definitely helpful vaccine, mask, sanitation. As of now, ivermectin has no role. Okay. So anything else in respiratory medicine? I think now we have got 4 questions here. There 5 questions. Okay. Yes. Option cough etiquettes. Yes, that is also helpful. Okay. Yes. Anything else, students? Any other questions that you can recall? And by chance, if you can recall, you can kindly send it to my Instagram, Bharat_Lungdoc. So I hope I'll not take much time. You must be all really tired. And don't worry, we are all with you. And wishing you all the best. And your hard work will definitely provide you success. So thank you and good night. Take good rest. Okay. Whatever has happened. Don't worry about it. You all have given your best effort. Definitely, it will be shown in your results. Yeah, dead space definition was asked. Okay. There is ventilation, perfusion will not be there. Ventilation is there, no perfusion. That is dead space. Okay. Anything else, students? Yeah. Okay, dead space is non. Dead space. There is ventilation, no perfusion. Okay, students. Good night. Take care.
All right, boys and girls, welcome to this INICET mega discussion session. Am I audible and visible to all of you? Can you please confirm so that I can quickly wrap up the ophthalmology segment since it has already been discussed by Dr. Saurabh. So I'll be quickly going through the questions which I had compiled. Please let me know if audio and video is clear at your side. Of the ophthalmology. All right. Okay. Great. All right. Wonderful. So in total, so I have received nearly 13-14 MCQs, which I am quickly going to discuss. Yes. All right. Wonderful. So starting with the first question, which of the following is true regarding OVDs, which is oculo-viscosurgical device? Yes, which is also known as viscoelastics, which is used in cataract surgery. Yes, if you could recall. So we have seen the video in the lecture as well, and we generally tell this particular thing, which is very important. So first and foremost, so which of the following is true? Yes, so it maintains the anterior chamber in capsular access and IOL implantation. So basically OVD is of two types. One is cohevisc, which is cohesive. Then there is dispersive. So I'm quickly going to tell you, right? So the dispersive one, it coats the inner layer of the cornea, which is endothelium, so that when you are operating inside the anterior chamber, even if you inadvertently hit the instruments at the back of the cornea, so endothelium is not damaged. It helps endothelium having some sort of a cushioning effect. Yes. Then there is cohevis, which is one is dispersive, I told you, another is cohevis. Yes. So when you inject it inside the anterior chamber, it maintains the anterior chamber so that you get the working area. Yes. So OVDs, they are used in maintaining of the anterior chamber, and they also help in capsular access. What is capsular access? Capsular access is when you actually remove the anterior capsule from where you need to extract the cataractous lens and you need to implant the artificial IOL. So for that you need some working area, na, hai na? So you require cohesive oculoviscosurgical device. All right. So coming over to the second question, which of the following is seen in diabetic retinopathy? All right. First, we need to understand the options which are given to us. What is retinoschisis? What is retinal detachment? What is retinoschisis? Retinal detachment is the separation of the retinal pigment epithelium with that of the neurosensory layer. The neurosensory layer are the inner 9 layers of the retina, while retinal pigment epithelium is the outer 10th layer. Yes, but retinoschisis is if there is separation between the neurosensory layer itself. Yes, so here the answer is pretty straightforward. It is tractional retinal detachment. Why it is straightforward? Because in diabetic retinopathy, in proliferative stage, wherever there will be proliferation, proliferative diabetic retinopathy, there will always be neovascularization. That is why we said na, it is a proliferative diabetic retinopathy. And when there will be proliferative diabetic retinopathy leading to neovascularization, that will ultimately lead to formation of fibrovascular membrane over the surface of the retina, which is eventually going to contract. When it is eventually going to contract, it is eventually going to pull the neurosensory layer from the retinal pigment epithelium. That is why we say that it is actually tractional retinal detachment. Yes, I hope you have understood. And of course, myopia has got no relation with that of diabetic retinopathy, and posterior staphyloma happens to be in myopia. Remember, staphyloma, when there is weakening of the outer wall of the eyeball with uveal tissue incarcerated, so that happens to be posterior staphyloma happens to be in the myopia. Yes, I hope it is clear, boys and girls. Yes, should I move ahead? So quickly we have discussed two questions, and now I'm going over to the third question, which is not present in inner segment of photoreceptor. Yes, so this was the question. So it was an integration between the ophthalmology and your anatomy. Yes, so the inner segment of photoreceptor, which is rods and cones, there is presence of Golgi bodies, there is presence of endoplasmic reticulum, there is presence of mitochondria, but one structure which is absent, which is not present, is actually the disc membrane. It is actually the disc membrane, one structure which is absent. Yes, okay, I had got the image. I'll just show you the image for better understanding. Let me just see if I can show you the image. I'll have to share one file with you. Now you need to tell me if you are able to appreciate. Can you appreciate this image, boys and girls? Can you appreciate the structure of rods and cones? And you can easily see that this is the inner segment. Yes, since this is the inner segment, you can actually see the mitochondria there. There is also presence of endoplasmic reticulum. There is also presence of Golgi apparatus. Yes, so disc membrane is not present. So this is just for you to understand. All right, is it clear? Yes, boys and girls. Yes, yes, is it clear? Yes, everyone. Dr. MS Alpana, Dr. Sai Jagannath Healthcare. Okay, yes. All right, I hope it is understood. So going back to our share of the file. Yes, okay, now coming over to the next question. So pterygium can lead to, what is pterygium? Pterygium is elastotic degenerative condition of the conjunctiva, and the most common etiology of pterygium is the exposure to ultraviolet rays. Of course, the other factors are also there: heat and dusty climate, tropical climate. Yes, and it can lead to macular edema. No, it has got no association with macular edema. Purulent discharge. No, it is not an infective condition. It is a degenerative condition. I told you, na, degeneration with respect to ultraviolet rays. Yes, corneal scarring or eye pain and astigmatism. Now see, this is kind of a confusing part. So corneal scarring, what happens is pterygium per se cannot cause corneal scar, but when you operate the patient with pterygium, so post-operatively there can be some corneal scarring, because pterygium has the ability to go till the anterior stroma. There are different layers of the cornea: A, B, C, D, E. Anterior epithelium, Bowman's membrane, corneal stroma, Descemet's membrane, Dua's layer, and then we have got endothelium. Yes, and it has got the tendency to penetrate deep into the anterior stroma. But when you cut the pterygium from the base of the cornea, so it can eventually lead to corneal scarring. But they have asked pterygium can lead to, so the answer will be astigmatism. And I am going to up the level a little bit. This is also your previous year NEET PG question. So astigmatism always happens along the axis of pterygium. Yes, you know that this is your y-axis, this is your x-axis, and if we talk about with the rule astigmatism, y-axis is steeper than x-axis. So what happens is, if there is pterygium which is coming over to the cornea, so it will eventually lead to flattening of the x-axis. So along the axis of the pterygium there will be flattening, so it is going to increase with the rule astigmatism. Yes. Okay, so the answer is C. Which of the following is seen in fundus fluorescein angiography in microaneurysm? So you are already aware of the fact that microaneurysms, they appear to be like small dots which are hyperfluorescent. Yes, what are microaneurysms? Microaneurysms are due to weakening of the endothelium. Why there is weakening of the endothelium? Because there's external support of the endothelium, which is pericytes. They are damaged. And why pericytes are damaged in diabetes? Because high blood sugar is toxic to pericytes, such that the normal pericyte to endothelium ratio is 1:1. 1:1. That means one pericyte is holding one endothelium, but due to dying of pericytes, so this ratio becomes 1:3. That means now one pericyte is holding 3 endothelium cells. Now you tell me, one pericyte will be able to hold one endothelium better, or one pericyte will be able to hold three endothelium better. Of course, one pericyte is able to hold one endothelium better, na, which ultimately leads to weakening of the endothelium, and there is formation of aneurysms. Now, since these aneurysms are getting developed in the micro vessels of the retina, so you call it as micro aneurysms. Yes, and when you inject the fluorescein dye in the antecubital vein, and after 11 seconds it appears to be in the retina, and you take red free photography with, of course, red free light, that is what I meant, and you will see small dots which will be hyperfluorescent. So the answer is A, which is hyperfluorescent dots which are there. Okay, now which of the following is not derived by neural crest? You know that there is what? There is protrusion. So there is prosencephalon. Consider me as a prosencephalon. Yes, so from the prosencephalon there is protrusion of the optic. So prosencephalon has a further part, diencephalon. Yes, so diencephalon, so there is protrusion of the optic stalk. This optic stalk later turns into optic nerve, and the distant part of the optic stalk forms optic vesicle, which forms optic cup. This optic, so this is optic stalk, this is optic vesicle, which transforms into optic cup. Yes, which transforms into optic cup. This optic cup is actually forming the retina. I am not going in depth to it. So this is forming retina. So the inner part of the cup forming neurosensory layer, and outer part forming retinal pigment epithelium. Now, you know, if you are planting मैंगो ट्रीज, यू आर नॉट गोइंग टू गेट गावाज आउट ऑफ इट. अगर आपने आम का पौधा लगाया तो उसमें अमरूद थोड़ी ना लगेंगे दोस्त, है ना. तो इसलिए ऑप्टिक स्टॉक इज अराइजिंग फ्रॉम प्रोजेनसेफ्लॉन, further diencephalon, which is neuroectodermal in origin, and optic stalk is leading to formation of optic vesicle, and optic vesicle is leading to formation of optic cup, which is later getting formed into retina. So all this optic nerve, optic cup, later into retina is neuroectodermal in origin. Hence it is the straight answer. It is the straight answer. Dr. Ekachi, the answer is retinal pigment epithelium, ciliary ganglion, ciliary muscles, choroidal melanocytes. You will mark neural crest. Yes, we have done this. We have done this in embryology. Yes, I hope it is understandable. Okay, identification of the layers of retina. So there was one image in which there were different arrows, and it was asked, wait, I'm just going to show you the image. So it may not be the exact image which was asked, but yes, I'll try to explain you a little bit. So check this out. So I hope this is very much visible. Now see, I just need your 2 minutes, and trust me, we will remember all these 10 beautiful layers of retina right now. Abhi ke abhi. Yes. Now you need to just conceptualize it. So dekhiye, innermost layer of the retina is which one? Innermost layer, of course, there has to be a membrane, hai na? So that is inner limiting membrane. You are already aware of this. So there is inner limiting membrane. Yes. Next is inner, do you know nerve fiber layer? What is the purpose of nerve fiber layer? ग्लॉकोमा का नाम सुना है? कहाँ सुना है? ऑफ्थेल्मोलॉजी में सुना है? काला मोतिया, सफेद मोतिया is cataract, काला मोतिया is glaucoma. In glaucoma, it is actually the nerve fiber layer which gets damaged. नाम तो सुना ही होगा, राजनी, nerve fiber layer, है ना? So nerve fiber, inner limiting membrane, then nerve fiber layer. Yes. Then we have got one beautiful layer which is ganglion cell layer. Ganglion cell layer. Ganglion cell layer, you can see the nucleus of the ganglion cell layer. Yes. Now, after seeing the nucleus, you can also see another layer which is inner nuclear layer. Now, one nuclear layer, another nuclear layer. If you want to join two nuclear layer, how they are going to join? They are going to join with the help of synapses. The synapses are known as plexus. So ganglion cell layer, then we have got inner nuclear layer. So they are joined by a plexus. This plexus is known as inner plexiform layer. Yes. Now inner nuclear layer, outer nuclear layer. So two nucleus again, they are going to join via plexus, outer plexiform layer. Yes. Now outer plexiform layer, then outer nuclear, then we had got inner limiting membrane. Now we have got external limiting membrane. So one was inner, another was external. Yes. Now we have got photoreceptors, and now we have got retinal pigment epithelium. Now you have to repeat after me. So the inner layer is, inner limiting layer. Then we have got nerve fiber layer, which gets damaged in glaucoma. Then we have got ganglion cell layer. Now, if there is ganglion cell layer which has got the nucleus, so there is another layer which is inner nuclear layer. Yes. So two nucleus are connected via plexus. So ganglion cell layer, inner plexiform layer, inner nuclear layer. If there is inner nuclear layer, there has to be outer nuclear layer. So inner nuclear layer, outer nuclear layer, again getting connected via plexus, which is outer plexiform layer. If there is inner limiting membrane, there has to be external limiting membrane. Now outer plexiform layer, outer nuclear layer, now external limiting membrane. After external limiting membrane, there is photoreceptors, which is rods and cones, and outside, the 10th layer is retinal pigment epithelial. So retinal pigment epithelium, I've got one question, I think. No, sir. In diagram, big rods and cone cells were seen, not a histopathy. I know. So Dr. Ekachi, this is what many students told me, but I just wanted to discuss the different layers so that you are able to understand it well. Yes. Okay. Colored cell layer, inner nuclear layer, and match ABCD wala tha. Yes, of course. So what I have got to know, you will correct me, Dr. Ekachi. So there were different arrows which were pointing towards different layers, and they had asked arrow A, B, C, D, or 1, 2, 3, 4. So 1 is this, 2 is this, 3 is this, 4 is this. Hai na? And the 4 options were, wait, I'm going to show you. This is what I have got. 4 options were retinal pigment epithelium, ganglion cell layer, inner nuclear layer, and outer plexiform layer. Is it correct, Dr. Ekachi? Yes. Please let me know. Is it correct? All right. So the basic idea was to make you remember the 4 layers, the 10 layers, and then you will be able to pick the 4 layers. Yes. Okay. Chalo. Aage chalte hain. I hope it is clear. Now, optic disc AV lumen ratio is, so basically artery is to vein ratio. Veins are slightly larger in size. They have got a lumen of large diameter as compared to the artery. So the answer is pretty straightforward. We have done it multiple times in our regular class, or in back to basics you will find it. So 2:3. But another important point I want to give here is, in hypertension it becomes 1:3. Why? Because the earliest feature of hypertension is arteriolar attenuation. Because of high blood pressure, there is reflex constriction of the lumen of the artery, such that it leads to the change in the AV lumen ratio from 2:3 to 1:3. Sir, RP, then ONL, then IPL, then ganglion. All right. Okay, got it. Yes, Dr. Abhishek, thank you. Okay. A patient came from a factory with a chemical injury to the eye few hours back. Which is the first step in measurement? First step in management. Yes. अब पहला step क्या करेंगे? A patient की आंख में, if something has gone into the patient's eye, will the patient be able to open the eyes? No, the patient will not be able to open the eyes. I got answers from students that they marked visual acuity. If something has gone into the eye, the patient may not be able to open the eye itself. So why you will do visual acuity? First thing is to do the irrigation, so that with saline, it should be with saline. Yes. So copious irrigation is required to flush out the chemical which has entered into the eye. Then you can go on for visual acuity. Then take history, slit lamp examination, take history, little bit of history the patient is going to give you. Of course, the patient, if something has gone into the patient's eye, the patient will not be able to come to you by himself. Na? Some attendants would definitely visit along with him, hai na? In the emergency. Yes. So later you'll do your other tests that are required, like IOP measurement. Yes. Okay. So yes, Dr. MS, irrigation करना चाहिए ना सर? Definitely irrigation ही करेंगे दोस्त. Okay. All right. What is the investigation of choice for best disease? अब देखिए, अगर हम बात करें, if we talk about the dystrophy of rods and cones, कोई बता सकता है what is the dystrophy of rods and cones? Rods and cones की अगर dystrophy की बात करें तो that disease is retinitis pigmentosa. Yes. Now the dystrophy of retinal pigment epithelium. Yes. Then there comes two diseases which are Best disease, and we have got Stargardt disease. Yes. Now in Stargardt disease, अगर हम Stargardt and Best disease की बात करते हैं तो यहां पर जो दो इन्वेस्टिगेशंस की रेलेवेंस होती है वो होती है EOG एंड ERG. यस, EOG इज इलेक्ट्रोओक्यूलोग्राम विच इज डायग्नोस्टिक ऑफ Best disease, which is diagnostic of Best disease, and in Best disease ERG will be normal. While in Stargardt disease, what can you tell me what happens in Stargardt disease to EOG and ERG? कोई बता पाएगा what happens? So in Stargardt disease EOG is normal. EOG is normal, and even ERG can be normal in the beginning, but later the ERG will be abnormal. So ERG will be abnormal. So later EOG can also become abnormal. Yes, I hope you have understood. Okay, but if I talk about retinitis pigmentosa, typically ERG will be abnormal. So these are 2-3 points that you should know. So based on this, which is the investigation of choice? You go for electrooculogram. What do you see in electrooculogram? You look out for Ardens index. Arden index is light peak divided by dark trough. The normal value is more than 1.85 or 185%. Yes, but abnormal value is less than 1.60 or 160%. Yes, I hope you have understood. Okay. Yes, very good, Dr. Abhishek. In Stargardt disease, signs are less, symptoms are more, but in Best disease, signs are more and symptom is less. Early disease, there is which stage? There is egg yolk appearance of the macula. While in late stage, in Best disease, there is scrambled egg appearance of the macula. Okay, now here, moving on to the next question. Yes, sir, retinal dystrophy only mentioned. So there was retinal dystrophy. Yes, retinal dystrophy. See, if we talk about retinal dystrophy, let's be specific. If we are talking of dystrophy of rods and cones, then there is retinitis pigmentosa. If we are talking of dystrophy of retinal pigment epithelium, then it will be Best disease and Stargardt disease. But what I have got from the students is that the Best disease was asked. Can anyone help me with this? Yes, was it the Best disease or it was retinal dystrophy? No, sir, clearly Best is mentioned. Okay, wonderful. So, dear Dr. MS, it was Best disease. Okay, so probably Dr. MS, maybe you are confusing with some other question. Best mention tha. Okay, thank you for confirmation. All right, don't worry, we'll further screen the questions which were asked, and then we'll come up with a proper recall after some time. Don't worry. So we at DAMS are always here for you guys, है ना? So best tha sir, maybe. Okay, all right. Now, which of the following leads to sudden bilateral painless vision loss? So if we talk about iridocyclitis, which is acute anterior uveitis in which there is inflammation of the iris and pars plicata of ciliary body, in this condition there is sudden painful loss of vision. तो यहां पे तो पूछा है सडन, तो आ गया, यहां पे पेनलेस की बात की जा रही है दोस्त. Yes, so iridocyclitis. Sir, the question, what is the best for retinal dystrophy? My dear Dr. Amulya, retinal dystrophy is a broad general term. In retinal dystrophy, we can have retinitis pigmentosa, which is one layer, which is rods and cones dystrophy. Then we can have Best disease, Stargardt disease, which is the another layer, which is retinal pigment epithelium dystrophy, है ना? Okay. Okay. So another is glaucoma. So glaucoma was acute glaucoma. Okay, I take it. So acute congestive glaucoma will also be sudden but painful loss of vision. But if we talk about open angle glaucoma, it will be slow or gradual painless loss of vision. Yes. Now keratoconus will also be slow, matlab gradual painless loss of vision, because there will be increase in the astigmatic error, which will ultimately lead to decrease of the vision. There can also be, there can also be thinning of the cornea, which will further cause protrusion of the cornea. Hence, you call it as keratoconus, which will lead to astigmatism, which will lead to loss of vision. Diabetic retinopathy, sudden bilateral painless. So there can be presence of vitreous hemorrhage. There can be macular edema. Do you know which is the most common cause of loss of vision in diabetic retinopathy? It is macular edema. Yes, but since the term sudden is asked, so vitreous hemorrhage, we are thinking of vitreous hemorrhage, but the answer here is diabetic retinopathy for sure. Yes, because I told you. Okay, Tanya is asking acute congestive glaucoma mentioned clearly. Yes, and Dr. Tanya, I have told you that here the loss of vision will be sudden and painful and painless in old age. So tractional retinal detachment was also there. Okay, एक second. Tractional retinal detachment was also there. Okay, and it was mentioned tractional retinal. I think, Dr. Tanya, you are confusing it with some other question. There was another question of tractional retinal detachment, and it was asked that tractional retinal detachment is seen in which condition, which I think we have discussed. है ना? एक second, I'll just clear your confusion once. So, no, it was asked which of the following is seen in diabetic retinopathy, and the answer was tractional retinal detachment. Okay, all right, all right. Okay, so I hope now it is clear. So the answer was yes. So the answer was diabetic retinopathy. Done. Okay. Now a 1400-gram child was referred to ophthalmology department with leukocoria and calcification with history of prematurity. What is the probable diagnosis? So we are talking of calcification. So you know that it is a straightforward question. Retinoblastoma is the tumor which has got calcification. And do you know which is the most common sign of retinoblastoma? It is leukocoria. So leukocoria is also the most common sign. But if we talk about Coats disease is a good, important differential diagnosis of leukocoria, and it happens to be in less than 10 years of age. Of course, there is another option, retinopathy of prematurity. In retinopathy of prematurity, leukocoria can also happen when there is neovascularization, which leads to retinal detachment. So it can also lead to leukocoria. Yes, congenital cataract, it can also lead to leukocoria. But here the catch point is your calcification. The catch point is calcification. Yes, hence the answer is retinoblastoma. Okay, which of the following is seen in macular corneal opacity? So there are three types of corneal opacities. How will you remember? A, B, C, D, E, F, G, H, A, B, C, D, E, F, G, H, I, J, K, L, M, N. So N is mild, M is moderate, and L is severe. Yes. So N is when there is kind of a see-through. You are able to see the iris, pupil, and its fine details, means crypts and furrows. M is when you are not able to appreciate the iris details, which is crypts and furrows. And L is when you are not able to see across the opacity. But here the options were pretty confusing. So the best answer here would be, so first just remove the options, eliminate the options one by one. So one is details, one is both iris and pupil details visible. No, why would both iris and pupil details would be visible? Yes. Then details of the iris visible. Details, if we are talking of crypts and furrows, I told you details. No, why the details will be visible on both iris and pupil margins, not visible. So if the margins are not visible, that actually tells me, you know, you're not able to see the margins at all. So probably they are talking of leukomatous. No, only pupil margin visible, only pupil margin. So I think the best answer would be only pupil margin is visible, because the details, crypts and furrows should not be visible. है ना? And both iris and pupillary margins are also not visible. Then it goes into the leukomatous category. So the best option here is your C, which is only pupil margin visible. Okay. All right. Now there was another question which I got. I'm just verbally going to discuss with you. Yes. So which of the following is seen in Behçet's disease? So one option was bilateral panuveitis. Second was ulcer on the dorsal part of the penis. I think third was Pathology test. I'm not sure. So if you could help me recalling this question, we can reach up to one answer. And yes, I think now we are running short of time as well. The other faculties must be waiting. So you can share your answer or share your question on WhatsApp at this number, and I shall respond to you. Yes. And Dr. Ekachi has a doubt, both visible in macular opacity. Please, Dr. Ekachi, iris and pupillary margin में yes question था Behçet's disease पर. Yes, what was that question, if you could help me? So one was about Pathology test. I'm not sure, this is what students told me. Second was bilateral panuveitis. Yes, bilateral panuveitis. And third was ulcer on dorsal aspect of penis, है ना, which is not present in diagnosis. What was the fourth option? Pathology test positive was there. Okay. What was the fourth option? The fourth option is still missing. Yes. Can anyone help me recalling the fourth option? Yes. Can anyone help me recalling the fourth option? Yes. Anyone? Yes, please. Not seen पूछा था sir. Okay, ulcerative colitis is more than celiac disease. It was fourth option. Okay. So that was on Behçet's disease. So there was only one component of bilateral panuveitis. Yes, bilateral panuveitis was there, and Pathology test is also used for diagnosis in Behçet's disease. There is aphthous ulcers in the mouth and also on the genitals, which is present. And do you know that there is bilateral hypopyon, which is also present? Yes. And now this is the statement, does celiac disease is more than ulcerative? So I feel the incorrect option should be this one, which is ulcerative colitis is more than celiac disease. Yes. So yes, this is all from my side. And that was about discussion of ophthalmology segment. And thank you very much. And in case you have any queries, any doubts, so you can always get back to me anytime you want to. So best wishes from my side. Take care, and yes, enjoy the time. Take 1-2 days off, and then you can, get back to your preparation for NEET PG, while hoping that you will get a beautiful rank in INICET November 2024 exam. Thank you very much. It is all my pleasure, boys and girls. So signing off, Dr. Manish.